Hello?
Yes, Doc.
Yes, Doc.
Okay, so okay na. Okay, so again, no, today we're going to discuss first the first topic, which is the specimen collection and handling for the diagnosis of infectious disease. Okay, so the learning objective of this lecture class is to discuss the general principles of appropriate specimen handling as to collection, transport, and processing. Okay, so remember again, no, appropriate specimen collection, transport, and processing are crucial in a pre-analytical steps in accurate diagnosis of infectious diseases. So the guidelines for the specimen collection are actually the main topics of our lecture, and the general principles are reviewed first, now followed by the discussion of the most common types of the specimen submitted to the clinical microbiology laboratory for testing. Okay, so again, no, a proper collection or a properly collected specimen in an immediate transport determines actually the success of isolations and identifications of organisms, particularly fungi. Okay, so like for instance, for the viruses, usually the timing of the specimen collection it should be done during the acute phase of the illness, whereas the bacteria, the best time to collect the specimen is before you give your antimicrobial agent to your patients, no? So before you give any antimicrobial agent, be sure you have a specimen collected from your patient. And then aside from the timing of the specimen collection, it is very important also to have an adequate volume. So the volume of the specimen collected class must be adequate for the performance of microbiological studies no requested. So if, like, for example, if insufficient volume is received in the laboratory, no, um, as a collector of the specimen, you have to notify, no, the healthcare worker caring for the patients, no. You have to notify the laboratory, no. So because very little specimen class obtained, like for example, okay, it may affect the results um of the results, no, of the microorganisms that we're going to um try to recover from the clinical sample. So like for instance, you're doing a swab and the volume is not properly collected. So there are times that the organisms of interest from the clinical samples will not be recovered. Okay, so if a swab is used for the collection, is to collect the specimen, it is very important, class, to use the polyester tip swab on a plastics shaft, which is acceptable for the most of the microorganisms, no? And the calcium alginate should be avoided, no, for this instance, for the collection of the samples, particularly, class, if you're going to collect it for a viral culture, like for example, herpes or herpes simplex virus. So by using the calcium alginate, class, it will inactivate, no, the herpes simplex virus. So the tendency is, if you're using the calcium alginate, it will result actually of not recovering, no, the organisms, no, like herpes of the of the interest, no, present in the clinical sample. So cotton may be toxic also to the Neisseria gonorrhea, so you should avoid also cotton, no, as a mode of equipment or tools to get the sample. Okay, and of course, the wooden shaft should also be avoided because the wood that you're going to use for the specimen collection will affect also or consider as toxic to the chlamydia trachomatis. So, um, and another one is inappropriate specimen collection. Like for example, again, swab. Like for instance, so the swabs are not optimal. Take note. If you're entertaining the cases of anaerobic or a mycobacteria or even fungi, no, the swabs are not optimal for detection for those of groups of organisms. And they should not be used when these organisms are suspected. So you're not going to use the swab as a mode of collecting device for a recovery or isolation of anaerobic mycobacteria or even fungi. Okay, so one of the best example class to get the tissue sample, for example, if you're entertaining anaerobic, so an actual tissue sample or a fluid aspirate is always superior, no, to the swab specimen. So I discourage you to use not to use the swab for the collection of the specimen if you're entertaining the infection caused by mycobacteria or anaerobic, or it could be a fungi. So again, cotton or swab is not appropriate. So it's best to get the um, tissue sample or a fluid aspirate. Okay, so specimen should be obtained from the site of infection with a minimal contamination. So again, proper collection, proper site of collection class. No, it's very important also to arrive the exact diagnosis. No, and again, the specimen should be obtained from the site of infection with a minimal contamination is always recommended to get the sample for isolations in culture. Okay, with the exception only for the stools, because there are times that we're going to use a stool as specimen for culture. So it should be, however, it should be collected in a sterile container. No, if you're going to collect the stool, and all the specimen class should be labeled with a name. So it's very important class, no, before you're going to submit also the specimen collected to the laboratory. Be sure that the specimen uh, is properly labeled with the name of your patients or with the identification number of that particular patient, the age of the patient, and then from whom the specimen was collected, no? And of course the source of the specimen. So you have to label also what is that source, what is that kind of specimen, and the date in time that it was be collected. So you have to put the date in time. No, and after collections and labeling of your specimen, it is best class to submit it immediately to the laboratory for testing. So after collection, no, the specimen should be placed in a biohazard bag. So it in after that, it must be transported to the laboratory as soon as possible if if a delay is unavoidable, like for example, such as urine or sputum in other respiratory specimen stool and the specimen, no, for the detections actually of certain viruses or microorganisms like chlamydia trachomatis, it should be refrigerated to prevent overgrowth of a normal flora. No, so it's better to refrigerate. However, class, for the CSF, for the CSF, and you're entertaining the causative agent is Neisseria meningitidis, no, and some other fluids like blood, no, and of course the peritoneal fluid and the rest of the fluid, and you're entertaining also the Neisseria gonorrhea, no, so CSF and other body fluids for isolations of Neisseria gonorrhea, the specimen should be held at room temperature. Okay, so why it should not be placed inside the ref or inside the refrigerator? Because the Neisseria gonorrhea and Neisseria meningitidis class are very sensitive to cold temperature. So again, if you're entertaining the isolation of Neisseria gonorrhea and meningitidis, and you have a specimen like CSF and other body fluids, so do not refrigerate, no, the CSF for Neisseria species. Okay, so it's best to held at room temperature because refrigerations again adversely affects the recovery of potential pathogen from these sources. Okay, so take note that class, no? Hindi lahat ng specimen, pag ma-delay kayo, ilalagay nyo sa ref. So there are some exception, like for example, kung ang nakareceive kayo ng specimen and the delay is unavoidable, again, and that specimen is for isolation and recovery of Neisseria. So do not refrigerate your specimen. So it is best to held at room temperature. Okay? So understood, class? Understood?
Yes, Doc.
Yes, Doc.
Okay. So with regards to the specimen transport, so if a delay after collection, if a delay is unavoidable here, no, the specimen should be placed before after collection, and then before you transport it, the specimen should be placed in a biohazard bag and transported to the lab as soon as possible. So as what I have said a while ago, okay, if the delay is unavoidable, okay, and you're entertaining for chlamydia and other viruses, so you should refrigerate that to prevent overgrowth of a normal flora. However, if you're entertaining the isolation of Neisseria, like Neisseria gonorrhea and Neisseria meningitidis, so it is best that the CSF and other body fluids and the rest of the specimen collected should be held at room temperature. Because again, as what I have said, refrigerations actively affects, the recovery of potential pathogen from these sources. Okay, so for the general collection guidelines class, the specimen quantity should be sufficient for isolation in direct microscopic examination. And take note, class, after collection, okay, the specimen should be transported to the lab, okay? In take note, class, the specimen should be transported less than 4 hours. Otherwise, if if a delay is unavoidable, so otherwise the specimen should be refrigerated at 4 degrees Celsius. And that's what I've said a while ago. Before you submit your specimen after collection and before you submit it to the laboratory, there must be a label with the patient's name, the site of collection, okay, the source of the specimen rather, the date and time of collection, okay, and of course the patient name. Don't forget that. Okay, other relevant information should also be indicated on the request form. So in every hospital institution class, there must be a request. Okay, so on the request form, you should fill up every detail on the request, including the specific culture site, the name of the collector of the specimen, and then any pertinent history, including the antimicrobial and antifungal therapy that were given to the patient. Okay, so you should state that on the request. Okay, so again, in the laboratory class, there must be a criteria for rejection of the specimen. Okay, we have to set a standard class in criteria when to accept and to reject the specimens. Okay, so one of the criterion class to reject the specimen is any specimen received in a formalin should be rejected. Another one, a 24-hour specimen sputum collection. So it should be rejected also, no? Okay, so another one is the specimen in container from which the sample has leaked. So there would be a leakage, no, on the specimen container. Okay, it should also be rejected. The reason why we reject the leak sample because of the possibility of contamination. So na-contaminate na yan class pag may mga leakage, no? So hindi na maganda ang results mo later kung contaminated na ang specimen na na-submit nyo sa laboratory. And the specimen that have been inoculated onto the agar plates that have been dried out or already outdated. So expired na class, dried up na. So you should rejected it. And the specimen contaminated with a barium and other chemicals class K. And of course, the specimen, especially urine specimen that has been collected at the fully using a fully catheter tips, so also be rejected. And of course, duplicate specimen, except blood samples, except for the blood culture, because in a blood culture class, it's a must to have um two sites of areas, no, collected for the blood sample culture. So duplicate specimen received in a 24-hour period, except only blood, no, should also be rejected. And of course, the blood catheter tips submitted, okay, for patients without contaminant positive blood culture, so it should also be rejected. Okay, so each of the laboratory class, no, in the hospital must establish a criteria for rejecting the specimen unsuitable for culture. Okay, and most of the hospitals now, they have that and agree that those specimens in complete labeling and signs of contamination should be rejected. Okay, so another one is criteria for rejection of the specimen for anaerobic culture. So again, if you're going to collect the sample from for anaerobic culture, no, like for example, you're entertaining clostridium, no, clostridium infections, no, the propionibacterium infection. So those are the anaerobic organisms. So again, um, in improper collections and improper collection should also be rejected. So, like for example, gastric washing. So gastric washing class is not appropriate for anaerobic culture. And another one, urine that has been collected other than the suprapubic. Like for example, midstream catch. So midstream catch is not suitable for anaerobic culture, but you can use that the midstream catch, no, if you're entertaining other not anaerobic. So like for example, facultative, aerobic. So you can use that the midstream cuts, but for anaerobic, so it should be rejected. Another one is stool, no, except only for recovery of Clostridium difficile for epidemiologic studies or for diagnosis of the bacteria associated with food poisoning, so you can reject the stool. Another one, oropharyngeal specimen, except those deep tissue samples obtained during the surgical procedure, no, sputum, no, swabs from ileostomy or colostomy sites and superficial skin specimens, so should be rejected. Okay, and take note, class, no, as a healthcare workers later on. Okay, the safety is very important. And take note, the laboratory director or a manager in the lab should collaborate with the infection control, with the institutional safety committees, environmental services, engineering, and others within the hospital in department to ensure class that there are current and necessary policies and procedure, no, proper PPE, engineering controls to prevent class, no, the cross contamination. So safety is very important for us. Okay, and the laboratory director or manager class is responsible for making sure that the policies of safety, the standard precaution procedures are followed. And the specimen processing can have an additional challenges because the workforce often has the least amount of formal technical education. Okay, and take note, take note, class, all the specimen that you were collected, class, and submitted to the laboratory, you have to consider that infectious. All the specimen that has been that have been collected for culture or taken from the patients you have to consider that they are infectious. No? So universal precautions were designated also to protect the workers from infectious substances, no? Like for example, blood and body fluids. And the isolation precautions were also be designated, to protect the workers from transmissions of organism from moist body surfaces. Okay, so the standard precaution is, again, as what I have said, any specimen taken from your patient, like for example, blood, all body fluids, secretions, excretions, no, except the sweat, regardless of whether or not they contain a visible blood. So you have to consider that all the specimens are said to be infectious. So you have to wear gloves, you have to wear PPEs, you have to protect yourself from acquiring infection, avoid transmitting, the organisms from the laboratory or from the hospital ward. So you have to protect yourself, class, no. Be sure you wear your proper PPE, no, or a personal protective equipment. Okay, so uh, when the specimen class or culture must be shifted to a reference laboratory, because there are times, class, that most of the institutions, like for example, in the request is highly sophisticated test, like molecular test, and most of the patients and most of the institutions in the laboratory in the Philippines, class, have no capacity actually to do the molecular testing for certain organisms, no, except for COVID, because now COVID laboratory has been already in place, no, in most of the areas. But some of the molecular testing intended for that organisms are most of the time they're not available. So it must be sent to the laboratory, referral laboratory, no, for testing. So when the specimen or a culture shift to the or shift to the reference laboratory, they must be packaged according to a dangerous goods shipping guidelines by the International Air Transport Association. No, so the specimen must be limited only to no more than 40 ml. So dapat hindi ka dun, class, lumagpas sa 40 ml. Okay? In a package containing category A substances. So like for example, kung category A yan, okay, it will be sent by the cargo aircraft, which is limited to more than 40 liters or 4 kilogram. So this volume of the or weight does not include the ice, no, the dry ice. Kasi pag na-package nyo yan, class, and ipapadala nyo, ipapashift nyo into reference laboratory, di ba na, dapat naka-properly package yun. And then, dapat nasa loob siya ng packaging, nandun may dry ice siya, no? May dry ice siya to preserve, no, the viability of your specimen, or naka-place siya, class, sa liquid nitrogen. And if any of these are used as a refrigerant. So, again, a package that contains the category A substance cannot be transported on a passenger's aircraft pag nag-exit ka doon, class, sa about 50 ml or 50 kilogram. Okay? So yun, class, yung standard, no? And again, temperature at which the specimen must be held during shipping, so you have to observe that. And the specimen contain a preservative may be regulated, no? So but most of the laboratory, class, don't accept kung ang specimen for culture placed with preservative. So hindi nila tinatanggap 'yon. Okay, unless there's a proper instruction for that particular specimen that needs to be placed with preservative, so pwede accept. Pero pag most of without proper instruction, so the tendency is rejection ng specimen nyo. Okay, so again, before you send your specimen to the reference lab, again, it should be it should be placed class in a properly transport container. Okay, it should be properly packaged, no? Like for example, if we're entertaining the cultures of bacteria and fungi, again, it should be placed in a cup of a primary container, meaning either is a tube or a vial, no, and it should be sealed with with a waterproof tape, and i-insert nyo yan class into a secondary container. So as you can see in the illustration, meron siyang meron siyang test tube. Okay, like for example, you have an infectious culture here, so it should be placed inside the test tube. No, and this test tube or vial should be sealed with the proper proof tape. Tapos i-insert nyo class sa second container na leak proof siya, no? And it is surrounded by a sufficient packing material to absorb the entire volume of the culture or the specimen if the primary container were leak or break, no? So after that, ipi-place nyo na siya ngayon class sa secondary packaging na leak-proof din, and it's properly labeled, no? So as you can see in the illustration, the secondary or the second container should be capped, no, and placed in a shipping container made of corrugated fiber board or hard plastic. And an itemized list of contents must be enclosed within the secondary and then the outer packaging, no? So the secondary and outer container should be sufficient strength to maintain class, no, the integrity of the specimen, or or the integrity of the temperature rather, in other pressurized other air pressures, no, to which they will be subjected. Okay, and then if the specimen must be shipped on a dry ice, no, and it must be marked na yung specimen na yan class naka ano siya sa dry ice, no, naka frozen siya sa dry ice. And the dry ice class should be placed outside, no, the secondary container. Wag sa ano ha, sa secondary container ha. Dapat outside mo siya ilalagay, outside the secondary container, no, with the packaging material in such a way that the containers does not become loose inside the outer container as the dry ice evaporates, no. Okay. Okay. So for the blood culture, again, this is one of the most common specimen that we receive in the laboratory. Okay, the blood culture. Okay, so blood culture are still the gold standard for identifying the bacteria responsible. For example, in-entertain mo may sepsis ang pasyente, may bacteremia, no? And then infections of prosthetic valves, no? Native valves, no? May mga suppurative thrombophlebitis, mycotic aneurysm, no, and the infection of vascular grafts. So blood culture class are recommended. So again, no, the blood cultures are useful also class, no, in diagnosing mga invasive or disseminated infection caused by certain organisms, no, or fungi. Like for example, for instance, no, Cryptococcus, mga candida, mga fusarium, no, and histoplasma. So again, blood culture is highly recommended. And serological testing or nucleic acid class amplifications are needed to identify two important bacterial causes of culture negative, no, culture negative endocarditis like your Coxella burnetii and then Bartonella. So the main purpose class of your blood culture is to detect the presence of organisms in the blood, to establish, no, the phase of infection, to determine the effectiveness of antibiotic treatment, and to assess the prognosis of your patients. Okay, so for the specimen collection for blood culture, again, the consensus guidelines recommend the peripheral venipuncture rather than draws from intravascular catheter. Kasi kung minsan class may mga intravascular catheter, doon na lang kumukuha ng dugo, no? So I think it's not appropriate. So therefore, peripheral venipuncture is highly recommended actually. And then before you get the sample, good skin cleaning and phlebotomy techniques to minimize the presence of skin contaminants in blood culture should be observed. And of course, before you do your venipuncture for blood culture, the use of iodine tincture or chlorhexidine gluconate is preferable to providon iodine solution. Why? Because because class the iodine tincture and the chlorhexidine gluconate requires only mga 30 seconds lang after applications to achieve the antiseptic effect, no, compared to providon iodine class na 2 minutes pa yung effectivity niya. Okay, and each set of peripheral blood culture must be drawn from a separate venipuncture site so that if typical contaminating organism is present in one set and not the other, the organisms can be more easily classified as contaminant. Kaya sa blood culture dapat dalawa, two arms ang site, ay sorry. Two arms ang site for venipuncture. So dapat may right and left ka. Dapat two sets of bottles for blood culture. Okay? Okay, class, understood? Any question? Hello?
One second po,
Okay,
Doc.
Kodo. Okay, so for blood culture, the timing. The optimal time to draw, if you're going to ask, what is the optimal time to draw? Of course, again, the optimal time to draw of blood for like, for example, for bacteremia or fungemia is suspected. The optimal time to draw is before the fever or chill. But again, these signs and symptoms are not predictable. Okay, so hindi mo minsan, ay nag-chills na ba ang ano mo? Kung minsan hindi mo kasi alam na nag-chills ng patient mo. So, tapos na pala siya mag-chill. So, doon ka palang kukuha ng sample. Okay, so but this is not predictable actually. So, the single most important factor to detect the bacteremia is of course the volume. So, the specimen volume, like for example, if you do your venipuncture for blood culture sa adult, so 20 to 30 ml ang kailangan class, no, per culture set. So like for example, kukuha ka ng blood for culture. So right and left dapat at least 20 ml or 30 ml sa isang arm. Another 20 to 30 ml sa isang arm. Kung two sets yan. Okay? So for the infants, it requires 1 to 5 ml, no, in children. Okay? So if you're entertaining class, no, if you're entertaining bacterial endocarditis sa mga pasyente na may bacterial endocarditis, it requires 2 or 3 na 20 ml. So ilan yon? Mga 30 to 60 ml blood samples drawn over a 24-hour period. So kung ang cases ng pasyente nyo for investigation is bacterial endocarditis. Okay? And the optimal time interval between the culture is unknown, but the 30 and 60 minutes for the first two sets has been suggested. So kung may mga class na hindi mo alam kung kailan na siya nakuha na ng dugo, so the optimal interval should be between 30 to 60 minutes for the first two sets. No? Kunwari, nakakuha ka na ng first two sets ng culture, ng blood culture. So, kailan mo siya ulitin? So, after 30 to 60 minutes or after 1 hour. Okay? So, again, there are important factors that could affect actually the recovery of microorganisms. No? So, the host factors is one, such as the antipresence of antibody, the complement, the phagocytic white blood cells, the antimicrobial agent. So, most of the time talaga, class, no? Bago ang mga clinicians na magpa-blood culture, binigyan na nila ng antibiotics. no, na broad spectrum. Even no, even tayo kahit kahit nga no, nagse-self-medicate tayo no ng antibiotics. So bago pa tayo na-admit sa hospital, umiinom na tayo ng antibiotics. So again, it's one of the factors that could affect actually the recovery of the organisms. No, most of the time talaga ay nakainom na pala ito ng antibiotic. Ay binigyan na ito pala ng antibiotic. So ano pang purpose ng pag-culture, no? Kaya most of the time walang growth, kaya nabibigyan, kaya kasi nabigyan na sila ng antibiotic. So therefore, class, various approaches has been used to counteract these factors. So in the laboratory class, even nabigyan sila ng ng antibiotics. Sa laboratory, we have actually yung aming blood culture, mayroon na siyang 0.02 or 0.05 na sodium polyanethol sulfonate or SPS no in blood culture medium, which inhibits actually the coagulation. So nagiging anticoagulant na rin siya. It inhibits also the phagocytosis and inhibit also the complement activations, including inactivations of antibiotics like your aminoglycoside. Kaya ang blood culture bottle, as you can see here, mayroon na yung SPS, no? Ang SPS is the sodium polyanethol sulfonate. So, ang SPS na yan, it inhibits the complement, inactivates also the aminoglycoside. Okay? So, again, one of the method actually for blood culture most of the time now is automated na, no? Automated na class ang ginagamit namin for blood culture. So there are three major automated continuously monitoring blood culture system are commercially available now. So we have a Bactic alert, no? We have also the BD Bactic, and then we have also the Versatric system. So yun na yung mga available na automated blood culture. So, ang Bactic alert is based on the colorimetric class detection no of a carbon dioxide produced during microbial growth. Sa machine na to na Bactic alert, mayroon niyang carbon dioxide sensor no. Um kasi ang culture bottle na yan na ginagamit natin, na nilalagyan niya siya ng blood sample, mayroon niyang CO2 sensor, no? Is banded to the bottom of each of the blood culture bottle. And it is separated from the broth medium by there's a membrane that separates to that, which is impermeable to most of the ions and components no of the medium or of the media in the blood no. So these inoculated bottles now, yung bottle na yan, no, yung blood culture bottle, ipi-place nyo na ngayon doon sa cell. Yun yung ginagawa, yung nakikita nyo dito. Yan, yung bottle na yan, nilalagay yan sa loob ng Bactic alert machine, no, or instrument, no, which provides a continuous racking of both aerobic and anaerobic bottles. So if the bacterial, for example, class is present, no, they generate actually the CO2. Mag-generate yan class ng CO2 which is released into the broth medium, and then the pH then decreases no causing the sensor to change the color from green to yellow. Kaya nga class no, pag na-close nyo na yan and then after 24 hours of incubation, magla-light yan kung may growth. Magla-light yan ng yellow. Pag walang growth, it remains green in color. So, ayan class, nakikita nyo ba yan yung yan. So, mag-iilaw yan ng yellow kung may growth, pero pag walang growth, green ang color. Did you understand, class? Hello?
Yes po,
Yes po,
Doc.
Doc. Yes po, Doc.
Okay, so this Bactic alert, no, the alert 3D system, no, this system supports actually the growth of aerobic and anaerobic bacteria. And the bottles are available to support the growth also of mycobacteria, no? Okay, so another one is ito yung sinasabi na Bactic, BD Bactic for blood culture. So this is also a continuous monitoring system for blood culture. So ito ay fluorescent technology naman. Ang Bactic alert is more of colorimetric yan, na ang minomonitor ay CO2. Ito sa Bactic BD naman, BD Bactic, no, it's based on fluorescent technology. No, fluorescent technology ang ginagamit. So it's bonded to the base of each of the vial. Mayroon din siyang CO2 sensor that is impermeable to ions, medium components in blood, but freely permeable to CO2. No? Kasi class, ang bottle na yan, mayroon yung special CO2 sensor, no, na makapag-detect ng CO2. Kasi class, pag may organism na nag-grow doon sa inside the bottle na may blood, mag-generate yan ng carbon dioxide. So ang mini-measure or ang dinidetect no ng mga bactic alert at saka mga bactic na yan ay yung CO2 na nag-generate kung may growth ng organism. Kasi may mga sensor yon yung bottle na yun sa bottom ng battle na yon. So, again, if the organisms are present, they release actually the CO2 into the medium and then diffuses into the sensor matrix and generate now the hydrogen ions, no? So, yan yung principles ng Bactic, no? BD, no? Yung BD Bactic. So the subsequent decrease also in pH increases now the fluorescent output of the sensor. And then magsisend yan ng signal transmitted to the optical and electronic equipments components of this instrument. No? So fluorescent technology yun. Okay, what about the Versatric? Ang Versatric, ito yung klase nakikita nyo. No, yung Versatric na yan, it detects the growth of organisms by measuring the gas consumption naman in gas production. So it's more of gas production in gas consumption. So you're using here a vial. So yung vial na yon is inoculated with a sample, and each inoculated vial is fitted with a disposable connector that contains a resist needle. So yung needle na naka-incorporate na doon sa Versatric equipment na yan, no, penetrates the bottle stopper and connects the bottle head space to the sensor probe. And the sensor now monitors the changes within the head space in the consumption in the productions of all gases. So, ang minomonitor din dito ay yung mga na-release na mga gas kung may organisms na present. Okay, so magre-release niya ng CO2, nitrogen, hydrogen, no? And these productions of all gases is the result of growing organisms, and it creates the data points internally in the computer. Kaya nga class, may nakikita ka dito na parang yan. Nakita niyo ba yung class na parang cellphone? It's a microcomputer sa Versatric. Did you see it?
Yes, Doc.
Yan. So, dyan na monitor nyo yung class, no? Dyan nag-create ng data points na kini-create yan sa loob ng sa loob ng machine, and nagre-reflect yan sa maliit na computer na yan. Okay? Okay, so yun yung mga technology class available for blood culture now. No? So hindi ka na mahirapan na ang dati. Diyos ko, magano ka, kuha ka ng mga itong volume ng blood. So konti lang, tapos ilagay mo doon sa medium, sa thioglycolate, tapos i-incubate mo siya. So ang tagal. And then may mga tendency na makontaminate. Okay? So for detection and notifications of the positive blood cultures, again, um, the positive blood cultures containing commonly the isolated aerobic, pag mga aerobic organisms class are usually detected yan within 12 to 36 hours of incubations. Okay, and now we have a highly sophisticated culture system to detect the positive results in the blood culture. So we have now the matrix assisted laser desorption ionization time of light mass spectroscopy, spectrometry, that is your multi-top MS. So makapag-generate na yan class ng positive blood culture for about 4 hours lang versus doon sa 24 hours. And then for anaerobic, again, cultures containing anaerobic are usually not detected for 48 to 72 hours. So it requires about 3 to 4 days, okay, of incubation to have a positive result. For the fastidious organism like your Haemophilus, no, Agrigobacter, no, Kingila, no, again, it requires 3 to 5 days of incubation to be detected. Okay? Okay, so for the viruses, again, for the viruses, with regards to the viruses, the blood specimen are most commonly collected to monitor the response of infection caused by HIV, HCV, no, hepatitis, cytomegalovirus, no, to antiviral therapy by using this quantitative PCR or polymerase chain reaction to measure actually the viral load. No, for the HIV and HCV class, yung blood specimen may also be collected for genotyping then, no? And then the PCR generally is used to confirm the initial positive hepatitis C virus antibody results. Okay? And again, PCR is also used for monitoring the levels of the Bakey virus and then Epstein-Barr virus, no? Okay, present in the serum or plasma. So you can use this also the quantitative PCR. So this monitoring class is indicated actually kung sa mga pasyente na may nag-underwent ng transplantation, organ transplantation. So they require no monitoring for the presence of BK and Epstein-Barr virus. Okay, so blood can also be used for detections of the parasites like like your Plasmodium, Babesia, yung mga trypanosomes, no, and then Pilaria. So sa parasite class, no, the most economical in the simple technique is the direct wet mounts of the blood, no? And this is also excellent for the diagnosis of trypanosomiasis or filariasis, no? And then to enhance more, no, the identifications of the organism. So that is why we use also stain smear, no, to make more definitive diagnosis. Okay. So again, in the parasites, like for example, for detections of the plasmodium, so we require actually a thin smear and a thick smear. So a thin smear, again, is for the speciating the plasmodium, the babesia, the panosome, whereas the thick smear are useful for detecting all the parasites mentioned and are part of a minimum laboratory workup for the diagnosis. Okay? So, so this is required only. This is required for the diagnosis of blood protozoan parasites and blood abnormalities, like for example, may presence ng anemia, no? Okay. So aside from blood, we use also CSF. No? Kailangan din natin class no mag-collect ng CSF in some occasions, especially when entertaining a diagnosis of meningitis no in a viral encephalitis. So again, infectious meningitis again it's one of the infections um to be entertained, and we collect the CSF as a part of our workup, no? So um again, this infectious meningitis class is considered as a medical emergency and requiring an early therapy to prevent no, the death or a serious neurologic complications, no? And the potential pathogens here are listed here. Okay, so in this infectious meningitis is divided into acute, subacute, no, and then chronic. So ang acute class, again, the onset or duration is less than 24 hours. Ang subacute is within 1 to 7 days, and then the chronic is 4 weeks, no, at least 4 weeks. And these are the probable organisms that we can we uh can be detected no or causing the infectious meningitis syndrome. And again, the agents these agents, no, among the common bacterial agents causing the acute meningitis can be subdivided, no, by the age group. No? So, for instance, neonates, ay sorry, ano ba to? Ay, ano ba yan? Okay, for the neonates and then the 3 months, the most common organisms causing the acute meningitis are the group B, Escherichia, no, Listeria, the Streptococcus pneumoniae. For the 4 months to 6 years, no, Streptococcus pneumoniae. For 6 years to 45 years old sa mga adults, no, Neisseria meningitidis. For the older patients, no, older than 45 years old, no, so most of the time streptococcus, no, listeria, and then the group is strep. Okay, so with regards to the examination of the CSF class, okay, the collection, no, again, the fluid, no, the CSF sample should be obtained at the lumbar region, no. So the needle is inserted into the lumbar region of the lower back before the termination of the spinal cord, no. So this procedure is called as a lumbar tap. So usually, ang CSF ay kinokollect yan between the third and fourth lumbar vertebrae, no. Itutusok nyo yung class yung needle nyo, be sure na nasa subarachnoid space kayo ng spinal cord, no, where the CSF is collected. Okay, and of course, the CSF um, must be collected in a 3 tubes. So this specimen should be handled also properly. So for the test tube 1, this is intended for the chemistries and serology testing. For the tube 2, okay, for this is intended for the microbiology cultures. For the tube 3, this is intended for hematology. Okay? So again, the CSF testing class is stat yun na. Dapat pag after collection, dapat tinetest yun agad. No? And take note, the CSF contains a potentially infectious agent. So you have to wear your gloves, no? Okay, in collecting, in transporting, or handling the specimen CSF, no? Because specimen potentially infectious in nature. Okay, so take note that class. Okay, so again, no, for the CSF, sorry. Okay, so again, no, for the CSF class, the parameters of a normal CSF and the usual changes here occur during meningitis caused by a different organism are summarized actually, no, like for example, for normally the CSF contains only 5 lymphocytes, no, per microliter, and the protein is only 15 to 14 to 45 milligrams per dl, and the glucose is 45 to 100. Okay, for meningitis, like for example, in bacterial meningitis, take note, the predominating cells are the PMN. Okay, the proteins is increased, however, glucose is decreased. Okay, and for the chronic, usually it reaches about 2,000, and also the protein is same, no, increase, and the glucose is decreased. Okay, for the tuberculous, no, and fungal, no, the predominating cells are lymphocytes. So again, the proteins are elevated and the glucose is decreased. For the enteroviral infection, it's actually a mixture of lymphocytes and PMN that reaches about 200. So still the protein is elevated and the glucose is decreased. Normal, sorry. Okay. Okay, so processing. So processing of the CSF class, no, for routine bacterial cultures include concentration, no, concentrations if 1 ml or more of the specimen is received, no, and preparation of the smear by centrifugations for staining with the gram stain in culture should also be recommended. So in the supernatant, ididecant nyo yan class into a sterile tube, mag-iiwan ka lang ng 0.5 ml of the sediment and fluid, which is thoroughly mixed on a vortex mixer or forcefully aspirating up and down into a sterile pipette. Okay, and then the sediment here, you have to place that on an appropriate culture media and do your also the gram staining. Okay. Okay, so for the diagnosis of a chronic bacterial meningitis, it requires also a specific request because the CSF is handled differently for each entity. So for the diagnosis of brucellosis class, the CSF usually incubated about 2 to 3 weeks. No, matagal ang incubation. For leptospirosis, it should be incubated about 2 to 3 weeks also, and then it requires also a testing using a nucleic acid. For the neurosyphilis, usually we require you to do testing also using a BDRL. No, so BDRL, this is a screening test for syphilis. No, so if the CSF BDRL result is negative in the presence of a clinical and serological testing, still it supports the neurosyphilis. No, so a CSF fluorescent treponemal antibody absorption test might be useful, for this case sa mga BDRL na negative pero clinically suggestive pa rin siya na is a syphilis yon. So kaya you have to request the fluorescent treponemal antibody absorption test. For detections of Borrelia burgdorferi, which is a causative agent of Lyme disease, so again, it's diagnosed serologically by detection of the specific immunoglobulins such as IgM and IgG antibodies in the CSF, including also in the serum. No, for the mycobacteria, actually, we require you to have at least 5 ml of the CSF. So kailangan ng 5 ml CSF for mycobacteria culture, and then the cytocentrifugation is required to make a smear and optimize the yield. And you can do also the nucleic acid testing. No, nucleic acid testing class is recommended. No, but a negative result in the nucleic acid testing, but with the presence of neurologic signs and symptoms, still no, you cannot exclude the mycobacterial infection. So still it's entertained. Okay, for the processing of the CSF for detection of the fungi, the organisms are concentrated by filtrations or by centrifugations, no? So these cytocentrifugations or a smear is required for staining with a gram stain or other stain used for this particular um, staining procedure and examine. And then the rest of the volume can be used for culture for detections of fungi. So you do your culture using the media like your brain heart infusion or a Saborod's agar brain heart infusion agar without antibiotics. Okay, so for the CSF, there are other additional diagnostic tests are available. Okay, so this is used for the diagnosis of meningitis caused by Cryptococcus neoformans. So we have already available the cryptococcal latex agglutination and the enzyme immunoassay. Okay, so for the CSF fluid sample processing with regards to the viral and parasite infection, so most often we use the nucleic acid testing for diagnosis of viral infection. And for the enterovirus, we still use the conventional still culture. But most of the time, class, the rest of the viruses for detection needs to be done serologically. Okay, so CSF can also be used for the diagnosis of certain parasitic infection like your African trypanosomiasis, and then the protozoan like Naegleria fowleri and Acanthamoeba species. Okay, so other body fluids can also be used, no, aside from CSF, like we use the pericardial, thoracic, or peritoneal cavity in synovial fluid for detections of infectious agent, no. So again, this fluid can be obtained by aspirating with a needle and syringe. So it requires 1 to 5 ml volume, which is adequate for isolating most of the bacteria. Okay, but for the mycobacteria and fungi, the optimal volume it needs to be 10 to 15 ml. For to improve the recovery, like for example, entertaining a peritonitis, okay, for recovery of the potential pathogen like your Coxsackie virus A and B, so it needs to be 50 ml. Okay, so the tissues can also be specimen. This tissue is obtained surgically for culture, should be placed into a sterile wide mouth screw cap container. So as a general rule, the tissue should be bisected aseptically by surgeon in the operating room, and the material representative of pathologic process should be submitted for both histopath and microbiological examinations. Okay, so the tissue that we receive in the laboratory is usually finely minced with a sterile scissors and scalpel. Then it rendered homogeneously either in the tissue grinder, mortal, or pisel. No? So dapat you have to observe class no the aseptic technique. Okay, so another specimen that we encountered in the laboratory is the conjunctival scrapings or swab, which are collected to determine no the etiologic agents, okay, of conjunctivitis, and among the most common bacteria implicated of in infectious conjunctivitis are those frequently implicated are Streptococcus pneumoniae, Staphylococcus aureus, particularly in adults. In children, it's more of Haemophilus and Streptococcus pneumoniae, and of course, including your Staph aureus. Okay, so trachoma is another reasons why we submit the conjunctival specimen for diagnosis of trachoma, which is caused by your chlamydia trachomatis, which is the leading cause of blindness worldwide. Okay, for epidemics of viral conjunctivitis like pink eye caused by adenovirus or herpes, so again, conjunctival specimen is another appropriate sample for investigation of the infection. Okay, so conjunctival specimen, again, you have to use the swab moistened with broth or a sterile platinum spatula. And then after that, you have to do your plating using a chocolate agar plate for recovery of the fastidious organisms and fungi. Okay, for the if you're entertaining viral conjunctivitis, you have to collect the sample in place in a viral medium, no, a viral transport medium or VTM for a nucleic acid testing. And for the chlamydia trachomatis, no, the nucleic acid testing are now the test of choice, no, for the diagnosis. Another sample that we encountered in the laboratory is a corneal specimen. Okay, so again, corneal scraping and biopsy specimen are useful for determining the etiologic agent of keratitis. No, and the infection that can cause a loss of vision and requires an immediate attention. So 65 to 90% of keratitis is caused by bacteria. In the United States, among the most frequently implicated bacteria causing your keratitis are Staph aureus, Streptococcus pneumoniae, and Pseudomonas aeruginosa and Moraxella. Okay, so aside from bacteria class, no, viral keratitis is also caused not only by viral keratitis is caused by viruses such as your herpes simplex virus 1, the varicella zoster, the Epstein-Barr virus, and adenovirus. Okay, so again, this corneal specimen is best collected using a sterile platinum spatula, no? And the media typically include for isolations of the bacteria are chocolate agar, especially used for recovery of fastidious bacteria, as well as the brain heart infusion with sheep's blood, especially entertaining for fungal isolation. Another specimen that we encountered is nasopharyngeal. Okay. So again, this nasopharyngeal is used for the diagnosis of bacterial pneumonia caused by Bordetella pertussis, no, Chlamydia trachomatis, Chlamydia pneumonia, or rarely the Corynebacterium. And this is used also for identifications of a carrier of methicillin-resistant Staphylococcus aureus. Okay, so with regards to the um, collection of a nasopharyngeal specimen, so you do an aspirate in washing, which are superior now for compared to your swab for viral recovery. And then washing or swab specimen are collected also for detection of Bordetella pertussis, no? Okay. However, there are times that the swab can also be used for detections of your chlamydia pneumoniae. No? Okay. And the most sensitive method for detection now of Bordetella pertussis is PCR or polymerase chain reaction. Okay, so nasopharyngeal specimen can also be used for detections of Chlamydia trachomatis. Okay, and this is collected using a polyester tip swab. Okay, so aside from nasopharyngeal, throat swab can be used also as a specimen for the diagnosis of bacterial pharyngitis in Vincent angina. And the most common cause of pharyngitis here, in less than one third of cases, is caused by a group A strep. No, so aside from throat swab, washing also useful for detections of viruses that is shed in the oral secretions without causing pharyngitis. So this include the herpes, cytomegalovirus, and then the enteroviruses. Okay, so this is how you collect class, no, the throat swab. Okay. So again, the throat swab specimens are collected by depressing the tongue, as you can see here in the illustration. So depressing the tongue with the tongue blade. Okay, or what you call this, the spatula, no, wooden spatula. Okay, and introducing the swab between the tonsillopharyngeal pillars, okay, and behind the uvula, no, without touching the lateral walls of buccal mucosa. So be careful that to prevent contamination. Okay, and then swabbing the back and forth across the posterior pharynx. Okay, and the swab specimen collected for detection of virus should be placed in a viral transport medium, no, the VTM. For the bacteria, you have to place it in the transport medium, the modified Stewart medium, and then avoid using the calcium alginate swab, especially if you're entertaining the detections of Neisseria gonorrhea. Okay, so swab can also be used for the diagnosis of group A strep, okay, and detection also of Neisseria gonorrhea, which is cultured using your modified Tire Martin. Okay, and for the diagnosis also for diphtheria, so throat swab is also recommended, and it is placed in a semi-solid transport media like your AMIS, no? And then the throat swab can also be used for detections of your Corynebacterium diphtheriae, okay, and this is isolated in a Tensdale medium, no, containing the colistin, nalidic acid agar, no? Okay. So for the sputum and tracheal aspirate, this is used primarily class to determine the etiologic agents of pneumonia and to assess also class no the mycobacterial infection. And the expectorated sputum is collected early morning before eating. So preferably class you we need 5 to 10 ml no ng sputum and tracheal aspirates. So for if you're entertaining mycobacteria, you need three samples. You have to collect three samples, at least one of which is an early morning specimen is recommended, no? And then the sputum and tracheal aspirate specimen should be collected into a sterile container and delivered promptly to the laboratory or refrigerated for a short time if a delay is unavoidable. No? So at this point, class, do you have any question? Class, at this point, do you have any question?
None so far po, Doc.
Okay, so for the sputum and tracheal aspirates for routine bacterial culture, it should be screened before they are plated to the appropriate medium to determine whether they are representative of a lower respiratory secretions or saliva lang. So paano mo siya class ma-screen? Paano mo siya malaman kung ang sputum is acceptable for culture? So you have to examine class under the microscope for the presence of epithelial and then the number of neutrophils. So kung ang sputum is acceptable, so there must be a fewer 25 epithelial cells and more than 25 neutrophils per low power field. So acceptable yon. Sputum nga yon, hindi siya saliva lang. Okay? And the tracheal aspirate is also used, okay, and using your gram staining no to determine um if there's no organisms are observed no in the gram stain. So for this tracheal aspirate in which no organisms are observed in your gram staining smear, it's subjected for rejection, no? So dapat mayroong organisms na makikita. Kaya nga class, before you do your culture sa tracheal aspirate, so gagawa ka muna ng smear to look for the organisms, no? Under the stained with the gram stain. Okay? So pag walang organism, rejected yun. For the sputum naman, so you have to make a smear and look for the epithelial cells. Pag less than 25, acceptable yan. And then more than 25 neutrophils per low power, acceptable yan. Okay? Okay, so for the specimen, sputum and trachea, this is used also for the diagnosis of infection caused by Burkholderia cepacia, no? Okay, which is one of the organisms implicated in person with cystic fibrosis. However, the most sensitive method for detecting also Bordetella pertussis because this is one of the other organisms that can be isolated in the sputum and trachea, so we use the PCR. For Legionella infection, okay, so both the culture of Legionella and a rapid direct test like fluorescent antibody on respiratory system or Legionella antigen or urine are recommended class for detection of the causative agent. Okay, so for the sputum class, no, for the optimal detections of the mycobacteria in the sputum, the specimen must be decontaminated first. Okay, so all the specimens submitted for the mycobacterial workup should be processed in a biosafety level 3 cabinet. No? So doon yun class ipaprocess. Wag yung sa open air because it contains the possible infectious agent like your mycobacterium. No? So if the sputum is viscous, okay, and the sputum specimen for the pneumocystis jirovecii, so you can use the DFA staining which are first treated with mucolytic agent using your N-acetylcysteine or dithiotritol, no? So i-ano nyo muna class, no? I-decontaminate, and then pag viscous, you have to treated with mucolytic agent. Okay. What else? Okay, sa mga sputum class, no, na may pneumocystis. Okay, so another one is urinary tract. For investigations of urinary tract, okay, the urinary tract above the urethra, remember, is sterile, but the urethra is normally colonized with the many different organisms or contaminants, no? So, urine specimen collected by a non-invasive method, so using your midstream catch or clean catch, no, before become contaminated during their passage, no? So again, for quantitative culture have been used to help to differentiate whether the contaminants or a presumed pathogen. So, if the colony forming units class of the bacteria are greater than 10 to the fifth colony forming units per ml, it can be considered highly indicative of infection. Okay, so that's how you evaluate it if it is a contaminants or not contaminated. Okay, so again, among the method acceptable for collections are the midstream catch, catheterization, the suprapubic, no? So those are the method acceptable for urine culture, no? And all the urine specimens should be transported promptly to the laboratory and should be processed within 2 hours, no? If a delay is unavoidable, the specimen may be refrigerated up to 24 hours. So, pwede pa siya class iparef. Okay, so in the processing, the urine should be, for inoculation, okay, the volume of urine should be 0.001 ml. So you have to use a recommended inoculating loop, no, to get the 0.001 ml to inoculate all the urine samples, except for those collected from women with the suspected acute urethral syndrome and suprapubic aspirates. For the stool, again, this is used for detection of certain viruses like your astrovirus, calicivirus, the enteric, adenovirus, and rota. No? So again, for stool, it should be collected in a clean container with a tight lid or in a VTM or viral transport medium. No? And the specimen should be delivered promptly to the laboratory, and the fresh tools can be stored at 4 degrees Celsius for up to 3 days and transported on wet ice. So, dapat class na nakatransport siya wet ice. Hindi nyo yan ilalagay class ang ice doon sa stool. So, dapat sa container. Sa container, di ba, may stool ka within the container. And then, it should be transported with another container with ice, no? Okay, so nucleic acid here is recommended also for detections of certain viruses causing your gastroenteritis and enteroviruses, no? So viral culture remains an alternative method for the diagnosis of adenovirus, entero, and parechovirus, no? And then EIA, enzyme immunoassay, is another option for detections of rotavirus and then adenovirus 40. No? So those are the viruses that can be isolated using your feces. No? So the stool specimen class should be collected in a clean container with a tight lid. No? And the specimen should not be contaminated with urine or any barium contaminants or toilet paper, because these substances can affect, the pathogen viability. And all specimen types should be transported to the laboratory within 2 hours and quickly processed, because class, the drop of pH that occurs as the stool cools may inhibit the growth of some of the pathogens. Okay? Okay, and for the diagnosis, this is used also for the diagnosis of Clostridium difficile. Okay, and it requires 20 to 50 ml class. Sorry. 20 to 50 ml of a liquid stool should be submitted in a sterile container, especially for the diagnosis of Clostridium difficile. No? And the stool is stable for about for 2 days when it is refrigerated. And it is stable for 1 week pag naka-frozen siya. Okay, so with regards to uh, a specimen processing of stool, again, no, the specimen received for routine bacterial culture should be processed to allow the recovery of other organisms like your Shigella, Salmonella, and Campylobacter. No? If the culture class is only available method, the stool specimen is inoculated into a sorbitol agar, no, containing the 1% D-sorbitol initiated of instead of lactose. Okay, so again, this medium, the sorbitol maconchi agar, is a selective medium and differential medium for the um variant strains of your Escherichia coli, no, which do not permit sorbitol from almost all other Escherichia coli, which are positive for sorbitol, no, and of course, sorbitol. Aside from culture, the detection of E. coli Shiga toxin can also be detected using your EIA or enzyme immunoassay and then the nucleic acid. No? For detection of Yersinia enterocolytica, you can use the agar using your CIN or cipsolidine ergasan novabiocin agar. For the Vibrio, you can use the medium for routine stool culture, but for their optimal recovery, you can use the thiosulfate citrate valsol sucrose agar. No, for Chlamydia trachomatis and Neisseria gonorrhea, you can use the nucleic acid amplification testing. So sorbitol feces can also be used for detection of Clostridium difficile, no, in which organism, no, causing the pseudomembranous colitis. Okay, so again, among the tests used for the Clostridium difficile infection, you can use the toxigenic culture, no? So this toxigenic culture class, okay, and including also the cell cytotoxicity neutralization assay or the CCA, these are the two reference methods for Clostridium difficile diagnosis, no? However, this toxigenic culture and cell cytotoxicity neutralization are slow and labor intensive. Okay, so therefore, nucleic acid alone or a combinations of your glutamate dehydrogenase antigen testing or a toxin detection by immunoassay is recommended as an alternative approach for Clostridium difficile detection. And the most effective method for this purpose, you have to use the CCFA or cycloserine, cefoxitin, fructose egg yolk agar, no? Okay, so the organism grow more quickly using this formulation containing the horse blood, no? That is your cycloserine, cefoxitin, fructose egg agar, the most effective medium. Okay, so any question about the specimen collection, processing, and isolation? Do you have any question, class?
None po, Doc.
Okay.
None so far po, Doc.
Okay, so let us discuss now, no, the immunohematology. Okay, just wait for a while, class. Class? Hello?
Yes po, Doc.
Yes
Yes
po,
po,
Doc.
Doc.
Okay. So again, no, this is the part 2 of our lecture. So we have to focus only the immunohematology because you have a separate lecture with the Doctora Espiritu regarding the transfusion medicine. So I'm going to focus my lecture on immunohematology alone, no, not on the blood transfusion medicine. Okay, so the objective of this lecture regarding the immunohematology, which focusing more on the knowledge and understanding about the ABO testing and result interpretation. At the same time, identify the types of ABO discrepancies and explain, no, the impact that discrepancies can have upon patient care and patient safety. And another one is to discuss the into regarding the accurate detection of the ABO discrepancy and apply, no, the serological techniques to resolve the error to ensure the correct ABO type is reported. And lastly, we will be able to discuss, no, the how the different test methodologies, including the tube method of agglutinations, um, in which produces a varying results with regards to discrepancy in the ABO blood types. Okay, so let us define first what is immunohematology. So immunohematology class, no, it actually merges the aspect of hematology, immunology, including genetics, no. So this branch of um, um, of medical science class, no, the immunohematology, it's actually a combination of serology, genetic, biochemical, and molecular study of the antigen associated with the membrane structure on a cellular constituents of the blood, no. So this branch of science, the immunohematology, it's more focusing on the immunologic reactions involving all the blood components and constituents. Okay, so primary in immunohematology class, we have a primary immunologic components such as antigens and antibodies. No, so these two reactants, no, provides a basis actually for the blood banking, testing, and reactions. So in the blood bank, we have a cardinal rule that the antigens are found on the surface of the red blood cell, and the antibodies are found in the serum or plasma. Okay, so what is the antigen? Antigen class are any substance that upon once introduced into the body, it gives rise to the formations of antibody that reacts specifically with the same antigenic substance. On the other hand, antibody is a form of protein, a gamma globulin, which is a product of immune response, no, that reacts with the antigen against which it is stimulated. Okay, so again, antigen, no, not all antigens class are immunogenic. There are certain characteristics of antigen that could affect their immunogenicity. So first is the chemical structure. It is said that the antigens are said to be immunogenic if they are protein in nature. And these antigen, which are primarily protein in nature, they can produce or they can induce the productions of immunoglobulin G, no? And those antigen composed of oligosaccharide, it tends to stimulate, no, the IgM type of antibody production. So the chemical structure of the antigen determines, no, the immunogenicity of the antigen to elicit an antibody production. Another one is the degree of foreignness, no. The more the antigens are foreign, they are more immunogenic. They are capable of eliciting an antibody productions. And then another one is the number of the antigen produced or introduced. So it is said that the higher the dose of the antigen that were given to the patients, to the patient's body, they can elicit greater the antibody production. And lastly, the route of administration. It is said that direct direct introductions of the antigen to our body, like for example, via intravenous or intraperitoneal routes, they are more potent than those antigen given or administered via intramuscular or subcutaneous route. Okay, so antigen class no are said to be immunogenic. No, so what is immunogenicity? The immunogenicity is the characteristic, the ability of the antigen to stimulate the production of its corresponding antibody in a person who lacks the antigen. So in blood banking class, we have several types of blood groups antigen. And the most among the blood groups antigen, Rhd antigens are said to be most potent antigenic, whereas the Duffy, particularly the Duffy or FYA, which is the antigen under the Duffy blood group, is said to be a poor antigenic. So based on the immunogenicity, the Rh group blood system are said to be immunogenic among the blood groups, no? Okay, and this is followed by the Kel, the Duffy, okay, and then we have also Kid in the MNS, no? Okay, so the RHD is the most immunogenic, okay, after your ABO blood groups system. Okay, so again, no, antibodies is is one of the basis for the immunological reactions in the blood banking. So as what I've said a while ago, antibodies are immunoglobulin products of an immune response that reacts with the antigen against what it's when which it is stimulated. So what is the antibody? This antibody, again, they are called immunoglobulin. They composed of protein. They are produced in response to the antigen. Okay, and they are specific for the stimulating antigen. So structurally, class, no, if you still recall, sorry for that for this picture class, it's not shown. It's black actually. It's not shown here. Okay, so but anyway, if you still recall that the structure of your antibodies consists of two heavy chains and two light chains, which are held together by a disulfide bonds, no? And and if this structure of your immunoglobulin are cleaved by enzyme, it produces actually a fragments, no? It produces a three fragments when they are cleaved by enzyme. So it produces two antigen binding fragments, that is your FAB, and then the crystallizable one fragment of your FC. So immunoglobulin class or antibody are classified. In fact, we have five types of antibodies. So we have your IgG, IgM, IgA, IgD, and IgE. No? So among the antibodies are mainly confined among the blood groups are your IgG and IgM. And IgG, as you will recall, are said to be smaller molecule will appear each of a heavy and light chain amino acid, no? So this antibody, the IgG, can coat only but not agglutinate the cells. Whereas the IgM can agglutinate the cells bearing a corresponding antigen. Because again, the IgM are much larger. They are pentameric in nature, so they can agglutinate the cells bearing the corresponding antigen. So these pentameric structure of your IgM are joined by together by the J chain. So here are the properties of your immunoglobulin class, no? So we have your IgG, okay, you have your IgM, and then the IgA. So each of these immunoglobulin has the H chain. Okay, like for example, for IgG, the H chains it's made of gamma, whereas the IgM it's made of the mu, and the IgG it's made of alpha. Okay, and the most abundant among the immunoglobulins are the IgG, which reaches up to 1,500 milligram per dl. Okay. However, they are much smaller compared with your IgM and IgG. So the IgM, the molecular weight is reaches up to 900,000. For the IgA, it's 180,000. For IgG is 150. Okay. And among the three immunoglobulins, the most the most competent to fix the complement among the antibodies is your IgM. Okay? So with regards to the structure, again, the IgM are said to be pentameric in nature. Okay, and they are joined together by the J chain. No? And for the IgG, it's monomeric and same with your IgA. But for the IgA, aside from monomeric, they have also dimeric structure. So among the immunoglobulins, the IgG can cross the placenta, no? So ang magko-cross sa placenta class among the immunoglobulin is your IgG, no? And the predominating, on the other hand, the predominating immunoglobulins in the secretion is your IgG. Okay, so at this point, class, do you have any questions? Do you have any questions, class? Hello po.
None so far, Doc.
Okay. So again, no, immunoglobulins in the blood groups class, they are classified into an allo antibodies or auto antibodies. So what is allo antibodies in the blood group antibodies? So allo antibodies, no, these are the antibodies that react with a foreign antigen not present on the patient's own RBC. So these most allo antibody class are produced as a result of a multiple stimulation of your immune system. Like for example, for instance, you had your multiple transfusions or you had a pregnancy and during delivery you're exposed with the blood of a newborn. So you develop an allo antibodies. So these allo antibodies again reacts with this foreign antigen that acquired or has been stimulated via transfusions or during pregnancy. No? So they react with this foreign antigen not present in the patient's own RBC. On the other hand, we have an autoantibodies. So the autoantibodies class, no, are those antibodies that react with an antigen on the patient's own cells with that same antigen on the cells of other individuals. So nagre-react siya sa patient's own cells and the same time it reacts with an antigen on the cells of other individuals. No? So that is your auto antibodies. Okay. So, any question, class? Any question before we before we discuss now
And so
the ABO blood
and
group.
so far po, Doc.
And so far, Doc. Thank you.
Okay, so again, no, ABO blood groups. ABO blood groups class, no, was first discovered by Karl Landsteiner in 1901. So this ABO blood group class, no, was classified by Karl Landsteiner. Okay. By the way, Karl Landsteiner is the Austrian scientist who identified the blood groups in 1901, no? So they classified as the O, A, and B blood types. So Landsteiner originally described the O blood type as the type C, as a type C blood type. And in parts of the Europe, it is rendered as a zero, no, signifying that it lacks this blood type, the zero blood type, signifying the lack of A or B antigen. Okay, so this Landsteiner class was awarded because of his discovery. He was awarded the Nobel Prize in Physiology or Medicine in 1930 for his work of discovering, no, the ABO blood groups. Okay, until 1902 class, no, in 1902, the Castillo and Storley discovered an additional phenotype of blood types. That is your AB. No? From his experiment, the Landsteiner deduced that the lack of A and B antigen resulted in the production of corresponding antibody by the individual. So that law in the absence of antibody in the particular blood types in the AB or blood group system is known as a Landsteiner law. Okay, so the ABO system class is the only system where the phenomenon occurs, no, in a Landsteiner law. Okay, so ABO blood group system class, no, is the single most important blood groups for the selection and transfusion of blood. Kaya nga class, di ba, bago ka mag-transfuse sa pasyente, kailangan mo muna malaman kung anong blood type. Di ba? Magsiselect ka muna kung anong blood type ng ita-transfuse mo. Dapat alam mo kung ano yung blood type ng donors mo at saka yung pasyente mo. Okay? So, again, this is the most important blood group, the ABO blood group, for the selection and the transfusions of blood. And it is widely expressed in most tissue. Makikita yan sa mga tissues natin, sa mga body fluids, including the red cells, the platelets, and endothelial cells. And under the ABO blood group, it has only 3 antigens. Tatlo lang ang antigens ng ABO blood group. No? So you have your A antigens, the B antigen, and the H antigens. No? So those are the 3 antigens under the ABO blood groups. And at the same time, in the ABO blood groups, it has also 2 major antibodies, no? So these 2 antibodies under the ABO blood groups are the anti-A and anti-B antibodies. So take note that class, there are 3 antigens and the 2 antibodies under the ABO blood group. Sorry. And And from this, no, under the ABO blood groups, there are 4 phenotypes also. So you have your A, the B, the AB, and the O, in which the A and B antigens of the ABO blood groups are said to be an autosomal codominant, meaning to say they are expressed on the group A, B, and AB red cells only, whereas the O phenotype is considered as the autosomal recessive. So they are not expressed unless the codominant phenotypes are absent. However, among the phenotypes, the O is the most frequent among the four phenotypes. Ay, sorry. So as what I have said, no, under the ABO blood groups, you have three ABO antigens. You have your H, the A, and the B antigens. So these ABO antigens, they are found on the surface of the red
Excuse me
blood
po,
cell.
Doc.
Come again?
Excuse me po, parang nagliit po yung slide.
Ay, lumiit ba? Hindi naka-full screen siya sa akin.
Ay, wait. I think
Yeah, naka-full screen siya. Okay, baka sa'yo, hindi, baka na ano sa'yo yung ano mo. Okay, so ano?
Na-update siya amin, Doc. Naka-landscape ang slide pero portrait po ang naka-present.
Naka-landscape sa akin. Hindi? Wait, come again. Just wait. Ayan. Hello?
Okay na
Okay
po,
po
Doc.
ngayon, Doc. Nagbalik na po siya
Okay.
sa...
So again, no, under the ABO blood groups, we have three antigens, the A, the H, and the B antigens. So again, no, these ABO antigens are present on the surface of the red blood cell as well as in the tissues and the endothelial cells in the body. They are found in soluble form. They are found in the plasma and other body secretions in people or patients known as secretors. They are inherited in a simple Mendelian fashion from an individual parents. Okay? So mayroon ka na-acquire ngayon class yung blood type nyo from your parents, no? Okay, so um these three, and there are also possible genes that can be inherited, no? These are your A, the B, and then the O, no? And the A and B genes are actually responsible for the productions, and they are detectable, and their products are detectable, no? Whereas the O genes are usually not expressed, so meaning they don't have any products that are detectable, no, unlike in your A and B genes, no. So meaning to say that the ABO antigens are under the control by a single gene known as the ABO gene, with the three types of alleles that inferred from a classical genetics, no. So you have your A and B genes that produces its product, and they are detectable. Okay, so the genes, these genes are actually encodes the glycotransferases, that is the enzyme that modifies the carbohydrate content of the red cell ABO antigens, no? In fact, the H is the precursor of your A and B antigens. Okay? So the genes that encodes a glycosyltransferase, this is an enzyme that actually modifies the carbohydrate content of the red blood cell antigens, and the gene is located on the long arm chromosome number 9. So this where can you find the the genes class that modifies actually the sugars of each of the ABO blood groups. Okay, so again, the H antigen, this is one of the antigen found in the ABO system along with your A and B. So, however, class, the H antigen, it served to be as a precursor of the ABO blood group antigen. So, meaning to say, precursor siya class ng H, precursor siya ng A, precursor din siya ng B. So these H antigens are made from the type 1 and the type 2 carbohydrate precursor chains, and they are found in the secretions, no? In the saliva, in tears, in the plasma, wherein the type 1 chains are converted into the H antigen by the enzyme action fucosylation by the secretor gene product. So meaning to say, dalawa ang klase ng H antigen mo. Mayroon kang type 1 and type 2. Ang type 1, these are the type of antigens that converts the H antigen by enzymatic actions which are found in the secretions like in the saliva or tears, no? Whereas in the type 2, these are the type of H antigen found on the surface of the RBC which are converted to H antigen by the enzyme fucosylation, and this is determined by the H gene product, no? So yun class yung H antigen. So the H antigen is the precursor of your A and B antigens. So what is now the role of your H gene here? So the role of your H gene in the expressions of your ABO, it's actually class determined, no? The the genes of your A and B resulting to its productions. So the inheritance of your A and B genes here is a result actually in the expressions of your A and B genes, particularly on the erythrocytes, but are not the direct products of your ABH gene, no? So each of these genes in the ABO class system are actually codes for the productions of the enzyme transferase. This transferase class, no, the glycosyl transferase catalyzes now the transfer of a monosugar or monosaccharide molecule rather from a donor substance to a precursor substance, no? So that is the function of your of these genes, no? So now, as what I've said a while ago, the H antigen is the precursor of your A and B antigens. And this H antigen is the precursor for the creation of a blood group A and B active structures, no? So there are two genes, no, which are responsible for the synthesis of your H antigen, So these are the FUT1, which are responsible for the synthesis of H antigen on a type 2 precursor, whereas the FU2 is responsible for the synthesis of your H antigen on a type 1 precursor, example in the secretions, which are found on a chromosome number 19, which encodes the sugar, which encodes the sugar and the enzymes of your H gene. So this H gene has actually produced an enzyme known as the L-fucosyl transferase, which catalyzes the transfer of L-fucose from the guanidiphosphofucose, no, donor to the terminal galactose of at least one of the precursor types. So ito yung class ang magkakatalyze class, mag-a-add ng sugar doon sa H antigen para ma-modify niya class, no, ang the rest of the precursor, which is your A and B antigens. So the enzyme that catalyzes, like for example for the A is the N-acetyl galactosamine, whereas for the B, the enzyme responsible is the galactosyl transferase, no? Okay, which responsible for the production of the sugar, catalyzing the sugar, which is your D-galactose, the B. Whereas in the type O, wala siyang enzyme class, kaya wala siyang gene products. Kita mo, yung mga blood type na type O, wala siyang A, wala siyang B antigens. Did you understand? Did you understood class? Did you follow?
Yes po, Doc.
Kasi since ang
Yes,
O
Doc.
genes, wala siyang enzyme, kaya wala siyang naipoproduce na mga antigen products. Kaya nga tingnan mo, ang type O, since wala siyang enzymes na-encode ng kanyang O genes, kaya it ends up with no antigen products. Unlike in your B, no, ang kanyang B genes, because of the enzyme galactosyl transferase, it adds the sugar, forming the D-galactose, so it forms now the B antigens. Whereas the A, i-add niya lang yung sugar na yon sa H, so by the enzyme here, it produces the D-galactosamine. No, that is the sugar of your of the sugar product of your A gene. So it will result to A antigens. For the O, wala talaga siyang end products. So the ABO blood group system has its own corresponding phenotypes, no? So, for example, since as each individual inherits, no, tayo, we inherit our our pairs of chromosomes number from our parents, no? So, as each individual inherits the chromosomes in pairs, a number of combinations are possible together to produce the ABO, the person's ABO genotypes, no? And this ABO genotypes class, no, which determinants of their ABO phenotypes, no? So, for example, if your phenotypes is A, so you have a corresponding genotypes of AA and AO. If your phenotypes is B, your genotypes is BB and BO, no? So if you have O phenotypes, you can only produce by the OO genotypes. Whereas the AB phenotypes can only be produced by the AB phenotypes. Okay? So therefore, class, therefore, there are 6 possible basic ABO genotypes that can genotype combination, but because the O gene is amorphic, meaning to say, class, amorphic, they are not expressed. There are only 4 observable phenotypes, no? Kaya mayroon kang A phenotypes, B phenotypes, and then O and AB phenotypes. So kung ang blood type mo is A, so you have a phenotypes of A, and then it will result to, it can produce a genotypes of AA or AO. Okay, and so on. Ay, hala, ano ba to? Sorry. Hala, pangit din. Hala, ay bakit? Sorry guys. Naku, naka-block. But anyway, class, no, I'm going to give you my PowerPoint lecture here, no? So, like for example, class, no, let us have exercise. So, if your mother's is blood type A and your father's is blood type A, what would be your possible blood type? What would be the possible child blood type?
Doc, A, B, or O po, Doc.
Saan napunta dun yung B? Saan nanggaling ang B? Kasi ang mother's blood type mo is A, and then yung father's blood type mo is A. How come you have a B? Di ba ang possible child blood types lang dapat is A or O? Tama? Kasi ang possible genotypes ng mothers mo and fathers is only AA and AO. Kaya wala ka dapat doon B. So pag may B doon, possible baka anak sa labas. So, pag ang mother's blood type mo is A, and then ang father mo is type A also, so ang possible blood type lang ng kanilang anak is only A and O. Understood?
Understood, Doc?
Wala ka dapat doon B. Okay? So, for example, let us do another exercise. If your mother's blood type is A and your father's blood type is AB, what would be the possible blood type of their children? Anyone? Again, ang mother's blood type is A and the father's blood type is AB. So, yun kunwari, yung blood type ng nanay at saka tatay nyo. So, ano yun yung mga possible blood type nyo lang?
Blood type AB tsaka A po, Doc.
Blood type A, blood type AB, and of course, may blood type B ka rin. May blood type B ka rin siya. Another possible blood type is B, A, and AB. Okay, what else? What if your mother's blood type is A and your father's blood type is O? Ano yung possible blood type ng children? Anong children nila?
Blood type A po, Doc, then blood type O.
Correct. Okay. What if class, ang mother's blood type is A and the father's blood type is B, what should be the possible blood type ng kanilang anak?
Blood type A, B, at saka AB, then O po, Doc.
Correct, no? So meaning 25% A, 25% AB, 25% B, and 25% O. So lahat, no? 25 A, 25% AB, 25, another 25 sa B, another 25 sa O. Okay? So that's how you determine, no, the blood types. The possible blood types. To predict the possible blood types, no? Last na lang na example. What if yung mother's class, ang blood type ng mother mo ay AB, and then yung blood type ng fathers mo is A, what should be the possible blood type? AB. AB ang nanay. Ang tatay mo ay A. So ano yung mga possible blood type ninyo?
A and AB, Doc.
A, AB, and B. Possible maging B ka, may B pa. Kasi remember, if you do remember, no, the possible father's genotypes here is the AA and the AO, and then the possible mother's genotype is AB. So pwede if you do your what we call this Punnett square determination, Punnett square to predict the ABO blood type, you do across determinations. So it will result actually at three possible blood types. So it will result the A, the AB, and the B. Okay? So last na lang. What if the blood types of your mothers is type B and then your father's blood type is B also? What are possible child blood types?
A ay B tsaka O po, Doc. B and O.
Correct. No, B and O. Correct. So, last na lang. What if the mother's blood type is O and the father's blood type is O? What are what possible blood types of their children?
O
O
lang po,
lang
Doc.
po.
Yes, correct. O lang. 100% O lang yun, class. Okay? Wala nang iba. Remember, ang O na yan ay malalabas lang yan kung walang mga codominants. Okay? Okay, so, okay na tayo dyan ha, class ha, sa blood typing. sa mga possible blood type. Okay, so among the ABO blood groups class, the most common blood groups is the O, followed by the A, followed by the B. In the least among the ABO blood group is type AB. Okay. So in the ABO blood groups, we have also a subgroups. So these subgroups, no, are the A and B subgroups. You have these subgroups in the ABO blood groups class because of the decreased amount of the antigen that are being expressed on the red blood cell. So they are inherited conditions. So hindi ibig sabihin na type A ka lang talaga, or B ka lang talaga. There are times na yung kahit A ka, mayroon ka mga subgroups A, mayroon kang subgroups B. Okay, and these subgroups are caused by a decrease in the number, or the amounts rather, of the antigens that is being expressed on the red blood cells. And the most common among the subgroups, the A subgroups is the most common. And approximately 80% of the A and the ABs have a normal expressions of the A1 subgroups. And most of the other 20% are either A2 or A2B. So meaning to say, class, among the subgroups between the A and B, the A subgroups is the most common. And among the A subgroups, the A1 is the most common subgroups in the ABO system. So these subgroups class, no, these subgroups has a fewer H chain, no, converted to the A antigens. Okay. Sabi nga natin, ang A, ay sorry. Iba yan. Okay. So ang sabi nga natin class, the H is the precursor of your A or B antigen. So these subgroups, no, yung mga subgroups na yan, has a fewer H chain converted to A antigens, resulting in a more H chain found on the red blood cell, but fewer ang kanilang A antigens. And some of these subgroups are weaker subgroups, no? Okay, so this could be either A3, the AINT, the AM, the AX, etc. So each of this has a different pattern of reactions using your anti-A typing sera and a various antibody-like substances called the lectins. So you know lectins are the substances that can be used to determine the possibility of other subgroups in the ABO system. So these lectins are the extract of seeds of plants that react specifically with certain antigen. And there are two most common lectins used in the blood banks. These are the Ulix europhaeus, or known as the H-lectin, which agglutinates only the cells having the H substance. Pag wala kang H substance or H antigen, negative ka doon sa Ulix europhaeus. So another lectins that used in the blood bank is Adolicos biflorus, or known as the A1 lectin. So this A1 lectin is specific only to agglutinate the subgroups of A, which is the A1 also. So kunwari, kahit type A ka class, pero wala kang A1 class, hindi ka dun makapag-agglutinate sa Dolichos biflorus. Kasi this lectin is specific only for the A1. Kahit type A ka pa, no, pero pag wala kang A1 subgroups, hindi ka makapag-agglutinate sa Dolichos biflorus. So that's how they're specific they are. So this lectin H, no, is strongest in the reactions with the O cells. So kung ikaw ay type O, marami kang H antigen. na naipoproduce. Kasi hindi na siya i-convert into another antigens or end product. Kaya tingnan mo class, ang type O, wala silang antigen na A and B. Pero ang antigens nila ay H. Wala silang antigen talaga pala. Wala silang H antigen, wala rin silang A and B antigens. But they have an antibodies. The antibodies A and B, and then the H antibodies. Okay, so this H lectin is strongest on the A cells, which has a higher concentrations of H antigen. I stand out to be corrected, class. Wala silang A and B antigens, but they have this H antigen, no? So kaya pag gumamit ka ng Ulexirofeus class, they have the strongest reactions among the O blood types because their O cells have a significant highest concentration with the H antigen. Okay, but weakest in the A1 subgroups, no, which have a low concentration of the H antigen. So here is the reaction of different blood types using lectins, the A1 and then the H lectin. So as you can see, using the lectin H, no, it has a strongest reactions in the O cells of the blood type O, and it has an weakest reactions with the A1B cells, and same also with the A1 cells. Okay, on the other hand, for the A1 lectins, as you can see, it has only reactions for those blood types na may A1 subgroups, including the A1 and then the A1B cells. But the rest of the blood types, they have a negative reactions. Okay? Okay, so in differentiating class, no, the subgroups of A, we have to use a different steps. So one is you have to use the A1 lectin to differentiate if the A1 cells is really the A1 subgroups from other subgroups because the A1 lectin is only specific to agglutinate on the A1 cells. Okay, and look for a weaker or a mixed field reactions and look for the anti-A1 in the serum in which the serum reacts only with the A1 cells but not the A2. Kaya nga class merong iba na class na kahit type A siya, no? Kahit type A siya class, it cause an incompatibility with or it caused a discrepancy in the ABO system. Kasi kahit A1 siya, kahit type A siya, no, it caused a discrepancy because mayroon siyang subgroups na A1. Okay? So to determine the presence of the A1 subgroup, okay, so you have to use the lectin, you have to look for the anti-A1 in the serum that reacts only in the A1 cells. And you have to look at the strength of the reactions with an anti-AB or with the anti-H. Okay, so I mentioned a while ago in my slides the Bombay blood group. So what's the difference between the O and the Bombay blood groups? Ang Bombay blood groups class, actually, wala rin silang H gene. And therefore, they cannot make the H antigen. Automatically, class, ang Bombay, if you do your blood type, pareho sila ng type O. Ang kanilang reactions, type O sila. So, however, sa Bombay blood groups, wala silang H gene. Unlike in your unlike in your type O, na mayroon silang H gene, kaya marami silang H antigen. Pero ang Bombay, since wala silang H gene, wala silang H antigen, wala silang H substance. Since the H substance is a precursor of A and B antigen, so these antigens are also not present on the Bombay blood group. Okay? So sa Bombay blood group, since wala silang H antigen, H gene, wala rin silang H antigen, wala silang A antigen, wala rin siyang B antigen. In the cell of your Bombay blood group, it looks like a type O. And however, the serum of your Bombay blood groups, it has actually an anti-B, anti-B, anti-A, and anti-H. So since the individual lacks of all of these antigen, however, they have these opposite antibodies or corresponding antibodies. Okay, so question. So since the Bombay blood group class, if you do your blood typing, it's same result with the type O. So question, is it if you do your transfusion for the Bombay blood group, is it compatible or is it recommended to transfuse the type O blood for the Bombay blood groups individual? Is it compatible ba sila class? Hello?
No, Doc. It's not compatible.
Why? Why is it type O blood type is not compatible or may cause reactions with the Bombay blood groups?
Because of the missing H antigen on the Bombay blood group, because the O antigen still has the H antigen.
Yes, because this has since the Bombay blood group has the anti-H antibodies, so it may cross react with the H antigen of the type O blood type. Kasi ang blood type O, mayroon siyang H antigen. Pero ang Bombay blood group, wala siyang H antigen, pero mayroon siyang antibodies or anti-H. So, kaya hindi compatible class ang type O na blood type kung ita-transfuse ko doon sa Bombay blood group kasi ang Bombay blood group meron siyang anti-H na magko-cross react doon sa H antigen ng blood type blood groups, ang type O blood groups. Kaya hindi pwede compatible ang Bombay at saka type O. So therefore, the only cells of the Bombay individuals do not agglutinate are from other Bombay blood group people since they are lack H antigen. So therefore, the only blood type na compatible siya class for the Bombay blood group is also a Bombay blood groups individual. Hindi pwede type O. Okay? Understood, class? Hello? Okay. So, in the ABO blood groups, again, you have your antibodies. You have your anti-A, anti-B. Okay, so these ABO antibodies are naturally antibodies. So, meaning to say, they are produced upon the stimulation of your immune system due to exposure or environmental exposure that occurs from birth. So, in the newborn class, no, actually, they don't have any antibodies of their own. Okay. From the beginning, they don't have antibodies. So the antibodies that are being detectable in the newborns are actually the antibodies that are transferred from the mother. So those antibodies that are being detectable class before 6 months are the mother's antibody yon. Okay. And the newborn are start only producing their own antibodies and they are detectable after 6 months. Kaya nga class, pag nag-blood type kayo sa mga newborn less than 6 months, ang bina-blood type nyo actually is the blood type ng mother. Kasi before 6 months, hindi pa ang mga newborn babies, they are not capable of producing their own antibodies. So yung mga antibodies na nadidetect nyo before 6 months are coming from the mother pa yan. So the newborns are start producing only their ABO antibodies after 6 months. Kaya sa mga blood type na, sorry, ano ba yan? Kaya nga class sa mga blood typing result before 6 months are actually it's not a true blood type sa mga newborn. But after 6 months, doon pa lang yan ang true blood type ng newborn. Kasi doon pa lang magsa-start ng production ng antibodies. So, most of the time, the ABO are naturally occurring antibodies. Predominantly, no, it's made of IgM in nature. No, and this is the predominant antibody among the group A and the group B individuals, and they reacts at room temperature after an immediate spin. But some of your ABO antibodies, they are IgG also, which is a predominant antibody among the blood group. No, and this group O individual has an antibody. Since wala silang antibody, antigens, they have an antibody, opposite antibody. They have an antibodies A and B, which are IgG in nature. Okay? Which is a predominant antibody in the group O individuals. Okay? So, any discrepancy class in the blood typing, like for example, if you encounter blood typing discrepancy in the ABO system, you have to, what you're going to do is you have to wash the cells with the saline for about 3 to 4 times and repeat the test for testing for antibodies. And you have to determine also the subgroups. Baka naman ang cause ng discrepancy ng ABO blood typing nyo ay baka naman may mga subgroups. So you have to use the anti-A1 lectin. No? So the anti-A1 lectin, ano nga bang anti-A1 lectin? What is the name of anti-A1 lectin, class? Dolichos biflorus. So the anti-A1 lectin is the Dolichos biflorus class. Okay, and another thing to resolve the ABO discrepancy is you have to use the cell panels to detect the specificity of abnormalities in antibodies encountered in your typing. So, understood, class, or any questions before we discuss now the RH? Hello? Any question?
None so far po, Doc.
Okay, so next we discuss now the RH. So the RH class was discovered actually in 1939 by Levin and Stephenson, who defined actually that those RH positive contains the D antigen, or also known as the RH factor. And on 1940, the Landsteiner and Weiner discovered actually that the anti-RH or the anti-RH or the anti-D agglutinate most of the human red blood cells, or 85% red blood cells. And the 15% remaining did not agglutinate it. Okay, so like for example, if you're considered as the RH positive, meaning to say you have the antigen in which it can agglutinate or cross-react or may react with your anti-RH or the anti-D. Okay, so therefore you have therefore you're considered as the RH positive. If you are RH negative, meaning you don't have any D antigen, so did not agglutinate using your anti-RH. The RH stands for the rhesus monkey. Now, this antibody of your RH blood group was similar to the guinea pig in rabbits antibody, which produced when they are stimulated with the rhesus monkey RBC. Kaya doon nanggaling class ang RH na meaning ang RH stands for the rhesus monkey. Hindi ibig sabihin class na nanggaling tayo sa monkey. Okay. So this antibody, no, was similar to the guinea pig at saka magre-react yun sa mga red cell. Kasi since nandun siya na-discover na they found that these antibody coming from the guinea pig in rabbits are produced actually are produced when they are stimulated with the rhesus monkey RBC. So nagpo-produce sila ng antibody. So although they were later shown to be different in name, however, their name remain, no? So the RH, no, I'm not going to discuss here, no, the nomenclature of the RH system. Pang medtech na yan class, no? Okay. So I'm going to discuss only the genetics here. Okay. So the RH, no, the RH have a three closely linked genes that controls the expressions of all the RH antigen. So these are the RHD gene and the RHCE gene. So ang RHD determines the expressions ng D antigen sa mga RH positive. Whereas the RHCE gene, ito naman yung nagde-determines ng expression ng mga CENE antigens sa mga RH individual. Okay, so the importance of the RH system class is that after the A and B antigens, the D antigen that was I'm already shown to you a while ago, the table, that after the A and B antigens, the D antigen is the most important red cell antigen in the blood banking. No, and the antibodies of your RH class is one of the cause of the transfusion reaction in causing the hemolytic disease of the newborn, or also known as an erythroblastosis fetalis. So this D antigen class can be used also, no, in the medical legal parenthood studies. Okay. So, to detect, no, the RH status, to determine the RH status of individuals, so we perform actually the RH typing. So this RH typing, no, is to determine the presence or the absence of the D antigen. So if you have if you have the D antigen, so you're classified as the RH positive. If you don't have any D antigen, you're classified as negative, RH negative. However, there are some individuals class in which some of their D positive RBC do not react on the immediate spin directly or immediately using a commercial anti-D. So they are classified as a weak D phenotype. So they are weak D. Now, question. If you're classified as a weak D individuals, are you also an RH positive or RH negative? Anybody? Hello? Class? Hello, class? Huh?
I
Hello?
believe it's still RH positive, doc, but it's just
Yes. You are
very
still
good.
RH positive. So take note, class, regardless of the reactions or your classification as either RH strong, RH positive, or weak D positive, or weak D phenotype, you are still classified as the RH positive. Okay? So, to demonstrate, no, the weak D phenotypes among the RH positive individual, since they do not react immediately using a commercially anti-D. So in this case, to demonstrate the D status, you perform the anti-human globulin testing to confirm if you're really an RH negative or RH positive. So, If you're positive on the anti-human globulin testing after the immediate spin testing using a commercially anti-D and you're classified as Rh negative, and however you confirm as positive in the anti-human globulin testing, you are still Rh positive. So there are some individual also class, these weak D, no, are classified as, or they are classified as a weak DU phenotype. The reason why you have a weak D expression is because of incomplete or a partial expression of the D antigens, or due to a position defect, no, during the process, or a weakened expressions of your D antigen. So that's the reason why you have a weak DU phenotype. Okay, so some are classified as a partial D. So this individual classified as a partial D or mosaic D, these are the patient. These are the patients if they are transfused with a D positive red cell, they develop an anti-D allo antibody, no, to the part of the antigen that is missing. As you can see here on the structure, the RBC of the partial D, there are some that is missing portion in which they don't have, no, they don't have they don't have the D antigen expression. So that missing on the surface of the red blood cell, once they are transfused with the D positive red cell, they develop this anti-D allo antibody. That is why on the next succession of transfusion of a D positive red cell, since they develop already the anti-D allo antibody on the first transfusion, even they are classified as a partial D or Rh positive partial D, they have a transfusion reaction. Okay, so that's the consequence actually. Another one is the D deletion, meaning to say this individual with a D deletion, they have no reactions when the red cell are tested with the rest of antibodies of the Rh blood groups other than the D. So hindi siya nagre-react doon sa mga anti-E, no, anti-C, and the small anti-C. Okay? So, this group of individual with the D deletions, however, they require transfusions of other D deletions. Why? Because if this individual may produce antibody with a single or a separate specificities, they react actually to that particular antigen. So magkukos na naman siya ng ng transfusion reaction. Okay? So this requires transfusions of another D deletion red cell because this individual produce an antibodies, no, with single or a separate specificities. So they have so those individuals are classified as a D deletion. They have a D negative or a double negative. For the Rh null, okay, these are the group of individual in which the red blood cells have no Rh antigen sites. However, since they have lack of antigen, it causes the red cell membrane to appear abnormal, leading to stomatocytosis or hemolytic anemia. Okay, so yun yung consequence ng mga individuals with the Rh null. So these two Rh, there are two Rh null phenotypes. So one is regulator, another one is amorph. So the regulator Rh null, they have a gene inherited but not expressed. So meron silang Rh gene, pero hindi naman na-express. Okay, so wala silang D antigen. There are some that classified as amorph type. So they have the RHD gene. Other RHD gene is absent. So therefore, there is no expression of all the genes in the RH blood groups. So yung isa may gene pero hindi naman na-express. Okay? Another, yung isa naman, they are classified as amorph kasi wala talaga silang genes. So wala silang RHD genes. Kaya wala rin expression ng gene products. So in the ABB standards, no, so those donor class classified as a weak D, they actually require to do testing, no. However, for those recipient classified as a weak D, they do not require now as a testing for the weak D for the recipient. So based on the American Association of Blood Banks, for the donors, they require weekly testing on all the donor red cells that do not agglutinate at an immediate spin. On the other hand, for the recipient, they do not require weekly testing anymore. Okay? Okay, but you have to establish the RH status of your patient, including the donors. So, just like your ABO, in RH system, they have also the RH antibodies. They have these RH antibodies are not naturally occurring in contrast to the ABO blood types. Ang ABO kanina is a naturally occurring yun. Pero yung RH antibody, they do not naturally occurring. They produce as a result of the immune stimulation from exposure to the antigen through transfusions or pregnancy. And these RH antibodies are implicated in most of the transfusion reaction. And since they are IgG in nature, they can cross the placenta and can cause hemolytic disease of a newborn, even in a first reaction, okay, on the first transfusion. Okay, since they are IgG, so they can cross the placenta and causing the hemolytic disease of the newborn. Okay, so again for the determinations of the RH, ano ba to? Okay. Okay, for the determinations of the RH, we do the RH typing either slide or tube method. But again, we prepare for the tube method because there are some cases that on a slide method, it can result to a false negative or a false positive. So among the causes of a false positive are results of a drying, but again, in some instances, the tube method, you will encounter also the false positive and false negative. But anyway, among the causes of uh, false positive results are drying, rouleau formations, autoagglutinations, the patient red cells heavily coated with antibody in the presence of cold agglutinins. Whereas the factors that could result to a false negative are the use of old red cells, wrong cell concentrations, hemolysis, inadequate mixing, inadequate typing, inaccurate temperature, because again, the RH are actually strongly reactive or strongly react at 37 degrees Celsius. Okay, so you have to use a correct temperature and the existence of the weak DU variants and high concentrations of blocking antibodies. So characteristically, the RH class are generally IgG in nature, except only the big anti-E. And this reacts stronger when the antigens are homozygous, okay, over your heterozygous. So those antibody, since they are IgG in nature, the RH antibodies are warm reacting and they are best react at anti-human globulin in 37 degrees Celsius and rarely react at immediate spin. So most of your antibodies in the Rh blood groups are considered clinically significant. Okay? Okay, so let us discuss now the hemolytic disease of the newborn. Okay, so what is hemolytic disease of the newborn? Is a destruction actually of the red blood cell of the fetus in newborn by antibody produced by the mother. And only IgG antibodies are involved here because it can cross the placenta. So not the IgA or IgM. So most of the involves antigens in the of the Rh in the HDN or hemolytic disease of the newborn are the antigens of the Rh and then the ABO system, but can result from any blood group system. But most of the time, the causes of your HDN are the antigens in the of the Rh and then the ABO blood groups. Okay, so remember, most of the time the HDN occur when the fetus is positive for an antigen and the mother is negative for the same antigen. So the HDN either caused by Rh or the ABO blood groups. For the ABO HDN class, most of the time is the result of incompatibilities, which are the most common cause of HDN. But if you compare with the Rh HDN, the ABO HDN are less severe. In about 1 in out of 5 pregnancies, these HDN are caused by ABO incompatibilities. And 65% of which no of the HDN are due to ABO incompatibility. So in the ABO HDN, usually the mother is a type O. So pag type O class, anong blood type? Ano yung antibodies? May antibodies ba doon? Or antigens? Pag ang blood type mo, ano yung antigens mo? Anybody?
For type O,
Yes.
doc, there will be antibodies for both A and B.
Yes, correct. If you're on type O, you have only antibodies. No, you have your antibodies A and B, but you don't have any antigen. So pag ang mother is type O, they have an antibodies A and B. Okay, but since the child has an A or B antigen, so they react to the antibodies of type O mothers. So causing now the HDN. So the HDN here, usually the mother is a type O, it's common in the type O, and the child is a type B or type A. So the group O individual, remember, have the higher titer of immunoglobulin G containing the antibodies A and B, in addition to having the IgM and anti-A and the anti-B. Okay, so again, most of the time they occur if the mother is a type O and the child is a type A or type B. So this ABO HDN can occur during the first pregnancy because the sensitization here is not necessary, unlike in your RH. Okay, RH is HDN. So the ABO can occur, ABO HDN can occur during the first pregnancy. And however, the manifestation and then the reaction here in the ABO-HDN is less severe than the RHDN because there is a less RBC destruction in the ABO-HDN. The reason why there are less RBC destruction because the fetal RBC are less developed at birth. So there's a less destruction by a maternal antibodies. Okay. Another reason, when they are delivered, the infants may present with mild anemia or normal hemoglobin levels, so they are less severe. compare with your RH. And another characteristic is that most infants will have an hyperbilirubinemia in jaundice within 12 to 48 hours, no? After the exposure. Okay? Okay, after birth. Okay, so in the ABO-HDN, they have a features of spirocytosis. You will encounter since there's an hemolysis, so you have an increased reticulocyte count as a compensatory mechanisms due to destructions of the red blood cells and the hemolytic process. And there's also an increase in your indirect bilirubin or B1 bilirubin in the first 72 hours. So in the first 24 hours, magkaka-jaundice yung bata class, no, yung newborn during the first 24 hours of life. So the good evidence for the ABO disease is detections of your anti-A or anti-B in the cord blood of the newborn. Okay? So, yun yung pinaka-best way to have a good evidence na yung cause ng HDN is really an ABO incompatibility. So, the HDN can also occur in RH. So, this most of the time occur when the mother is the D negative and the child is the RH positive. So, they have D antigen. So, the child is RH positive because of they have D antigen. And comparing with the ABO HDN, the RH HDN is most severe. And 33% in fact of the HDN is caused by the RH incompatibility. So comparing with the ABO, the RH-HDN requires sensitization, usually occurs very late in the pregnancy. So the first RH positive child is not yet affected. Okay, the reaction usually occur on the second pregnancy, no, since there is a prior sensitization. Okay, and this HDN, no, in the RH, usually the exposure of the mother with the RH D or the RH antigen usually bleeds most often occur at delivery. And that is the time that the mother is, most of the time they are sensitized with the RBC with the fetal RBC or the newborn's RBC containing the D antigen. And the subsequent offspring that are positive on the second pregnancy, they are already affected. So here is the illustration showing again how this RH-HDN occur. So usually when the mother is RH negative and married to RH positive man, and they conceive, no, the RH positive fetus, which the blood cells containing the D antigens enters into the mother's bloodstream. And then these women become sensitized, producing an antibody, no, to fight later the RH positive blood cells. On the second pregnancy, now since there's a sensitization of this woman, now the RH positive pregnancy, the maternal antibodies now attack the fetal red cells of the fetus with the D antigen on the second pregnancy. So since the RH class, no, is IgG in nature, they can cross the placenta and attaches to the antigen on the fetal cells. So they are sensitized. Sensitized red cells are removed, no, by the macrophages in the spleen and result to a destruction, but depends on the antibody titer in the number of the antigenic site. Okay? And take note, class, no? The IgG lifespan is 25, so the 25 days, so the condition can range also from days to weeks. So ganun, class, ang manifestation sa RH. Since ang cause nito ay IgG, since the RH, the anti-RH is IgG in nature, so ang lifespan niya is 25. So ang manifestation or ang condition can range from days to weeks din. And the RBC destructions in anemia cause the bone marrow to release the erythroblast. Now, therefore, this HDN is known as your erythroblastosis fetalis. Okay? So, since may anemia ka dito, since may destruction ka ng red blood cell and may anemia secondary to hemolysis, so it can involve your bone marrow to release more erythroblast. Kaya may mga erythroblast ka, class, makikita sa circulation ng newborn. So, when the erythroblast, class, are used up, what happened is that the bone marrow now, the hematopoiesis in the bone marrow will shift into the spleen in the liver, no, in the newborn. So that is why it does explain also the hepatomegaly, no, in patients with HDN-RH or hemolytic disease of the newborn caused by the RH. No? Okay, and there's also the hypoproteinemia, no, because of the decrease in the liver functions. Okay, this leads later on to cardiac failure edema known as a fetal hydrops or hydrops fetalis. So since the hemolytic in nature, you have a productions of this pigment known as bilirubin. So before birth, the indirect bilirubin is transported across the placenta and conjugated in the maternal liver, where it is excreted. However, after birth, the newborn liver now is unable to conjugate the bilirubin, so you have an increase, you have an increased conjugated bilirubin, no? But again, this unconjugated bilirubin can reach a toxic levels, up to 20 milligrams per DL, causing a carnecterus, which leads later on to permanent brain damage. Okay, so how would you prevent the RH incompatibility in the hemolytic disease of the newborn for maternal for the mother? So you have to give the immunoglobulin within 28 weeks. So the ROGAM here, the immunoglobulin, is given to the mother to prevent the immunizations of the D antigens. No? So the ROGAM, what does the ROGAM do? They attaches to the fetal red cell in the maternal circulations and they are removed in the maternal spleen. So this prevents the allo immunization by the mother. Okay, so the immunoglobulin here is, however, is no use once the person has confirmed already na mayroon na siyang anti-D. No? And it is very important, class, to distinguish the presence of anti-D as the residual immunoglobulin from the previous dose or a true immunization from the exposure to for the D positive red blood cell. Another one is the ROGAM or the RH immunoglobulin is not given to the mother if the infant is negative. So pag negative naman ang infant, so do not give the ROGAM. Okay. Okay, so here is the comparison between the ABO and the RH HDN. So please see on this class. No? Okay, so at this point, do you have any question, class?
None so
Hello?
far.
None so far, Doc.
Okay, so let us discuss now the red cell serological techniques in the blood banking. So we have the ABO, the weak DO testing, the anti-human globulin. no, the pre-transfusion testing. Okay, so one of the most common blood banking procedure that we actually perform is the ABO typing. No, so the ABO typing here involves the antigen typing and then the antibody detection. So the antigen typing is the direct typing, whereas the antibody detection is the reverse typing. So in the ABO grouping class, we have to establish, no, the blood type by determining the presence of antigen or antibodies using a typing sera, which is the principles behind the forward or cell typing. Whereas in the reverse typing, we have to establish the presence or the absence of antibodies using the known red blood cells, no, to know the presence, to determine the blood types using a reverse or serum typing. Okay, so here the forward typing determines actually the antigen determinations on the patients or a donor red cell. So here, no, in the forward typing, the cells are tested with the anti-sera reagent, anti-A and anti-B, and in the case of the donor cell, the anti-AB. So the reagents are either made from hyperimmunized human source or monoclonal, and the monoclonal now is more advantageous, no, because it provides a greater strength with an antibody. And another advantage of monoclonal, the human source of reagent can transmit, no, the infection. So therefore, we provide more advantageous the monoclonal. So here is the forward typing, no. So in a forward typing, we use actually, no, the patient's or the donor's red cell um, that made to react with the typing sera anti-A and anti-B. So if there's no reactions after the additions of anti-A and anti-B typing sera, so therefore you are blood type O, since you don't have any antigens that reacts with your typing sera. If your blood type is A, so meaning to say you have an antigen A that made to react with anti-A, so therefore you have a positive agglutination. If your blood type is B, meaning to say you have the B antigens that made to react only with your typing sera anti-B, so therefore it causes agglutination. So your blood type is B. So if your blood type is AB, since you have both A and B antigens present on the red cell, so upon additions of anti-A and anti-B, so there's a reactions with your typing sera. So therefore, your blood type is AB. So did you understand on this class, the forward typing? So the forward typing, the patient red cell against the known typing sera A and B. Class, did you understand? Did you follow this?
Yes po, Doc.
Okay, so another method of blood typing is the reverse typing. So in the reverse typing, it determines actually the antibodies present in the patient's or a donor serum or plasma. So here in the reverse typing, we tested actually the serum against the known B cells and the A cells. So if your blood type is your blood type is O, since you have anti-A and anti-B. So since we use the known A cells in the B cells, so since the A cells in the B cells have also an antigens A and B, and if your blood type is O, you have also anti-B and anti-A, so it made to react with both cells here, so causing agglutination. So your blood type is O. What if, class, in the reverse typing, um, if you have agglutinations with the A1 cells and you don't have agglutinations with the B cells, so what's your blood type? Again, if you have an agglutinations with your known A1 cells and no agglutinations with the B cells. What is your blood type? What is the patient's blood type? May agglutination ka class sa A1, sa A cells, pero wala kang agglutination sa B cells. So anong blood type mo sa reverse typing?
B po, Doc.
Yes, B. Because again, the B individuals or the B blood groups have actually the antibodies or the anti-A antibodies that made to react with the A cells. Okay? So what if class you have no agglutinations in both A cells and B cells? So what's your blood type?
AB, Doc.
Yes,
A.
AB. Because again, the AB have no antibodies A and antibodies B. Okay? Kaya walang reaction, hindi siya magre-react doon sa known A cells and the B cells. So take note this class ha. Ang A1 cells and the B cells have the antigens. Ang antigens natin makita doon sa mga red blood cells. Ang antibodies makita sa serum. Kaya sa reverse typing, ang dinidetermine natin dito ay antibodies na makikita sa serum or plasma. Okay? Okay, so here is the table to show you again the results of your blood typing or your reverse typing using the known A cells and the known B cells. So take note, if your blood type is O, since you have both anti-Bs and anti-As and anti-Bs, so it makes to react with the both cells. So you have an agglutination. If your blood type is A, so since the type A has an anti-B antibodies, so it made to react only with the B cells, not in the A cells. Okay, if your blood type is B, so meaning to say you have antibodies A that may have to react only with the A cells containing the antigen, so your blood type is B. So if your blood type is AB, so you don't have any antibodies A and B, so it doesn't react with the both A1 and B cells. Wala na yung class. Discrepancies. Okay, so again, this sometimes class, the ABO discrepancies is caused actually by the ABO testing. There's a discrepancies between the results of your forward and reverse. Okay, because of the technical issues such as incorrect identifications, the patients or a donor serum are not added during testing, reagent contaminations, over centrifugations or under centrifugation, hemolysis, or warming of the test mixture. Or it could be missing antigen, antibodies, or acquired B in which the patient has a colon CA or gastric CA, or due to a polyagglutinable RBC, or you have this antibody-coated red blood cell during transfusion, or maternal fetal agglutination. Or it could be a Rolu formation, or it could be anti-A1. So many causes of ABO discrepancies. So what to do, class? If you encounter ABO discrepancies, you have to wash the red cell for 3 times and repeat all the tests and test for antibodies. You have to test also the subgroups. Baka yun yung cause ng ABO discrepancies. Or you have to use the cell panels to detect the specificity of abnormal antibodies. Okay, so again, before the results that is being released, okay, you have to resolve first, no, the issues or the discrepancies. So the results of the forward and the reverse typing must agree before reporting out the blood type as seen in the table, no, previously. So if the forward and reverse do not agree, you must identify the cause of discrepancies that I have mentioned a while ago. If you cannot resolve the discrepancy, you must report out the blood type as unknown and give the type O blood type if necessary, if there's a requirement for the transfusion, if there's an immediate requirement for the transfusion. So you have to, the safest blood is to give the blood O, the blood group, the type O red blood cells. No, the packed red blood cells, type O blood type. If you don't know the type of the person, but it's an emergency, the safest blood to save the lives of your patient is to give the packed O red cell. Okay? In emergency only. Pero pag hindi emergency naman, you have to establish the blood type, you have to resolve the discrepancy. So the laboratory, in the laboratory class, we test also the RH. We have to determine the RH status of the individual using the commercially available anti-D. So what you're going to do, you have a patient's or a donor's blood type, and you have to add only the anti-D typing sera. So if the D antigen is present, it should agglutinate with anti-D typing sera, even at immediate spin. See, if you are RH positive, meaning mayroon kang D antigen. Pero pag wala kang D antigen, you're RH negative. So sometimes, as what I have said, class, there are individuals that are weak DU. So they are, you have to perform the weak D testing, no? So the anti-D and RH are negative, no? You have to perform the weak DU. So regardless, no? Basta class, on the immediate spin, walang reaction, you have to confirm really if the patient is RH negative or not. Pag RH negative siya, sa weak DO testing mo, so it confirms that the patient is RH negative, really. Okay? So like for example, sa direct typing RH mo, may agglutinations immediately, so hindi ka na mag-perform ng weak DO. Pero pag sa immediate spin mo, using a commercially available typing sera, no, nag-negative, walang reaction, so you have to confirm using the weak D testing. Okay? So there are two types of human immunoglobulin class, no, testing. Okay, so you have your direct and you have your indirect type P immunoglobulin. Okay, so the direct and indirect anti-human globulin test is also known as the direct COMS test and indirect COMS test, respectively. So these two tests are used to detect the presence of antibody or the complements proteins that are present on the red blood cells. No? Okay, so these tests, no, both tests involve the use of antiglobulin reagents, and they differ in their applications in purpose. So for the direct COMS test or a direct anti-human globulin, the purpose of this is used to detect the antibodies or complement proteins that have already coated the patient's red cell in vivo. It is primarily used in the diagnosis of autoimmune hemolytic anemia, hemolytic disease of the newborn, and other conditions involving the immune-mediated destructions of the red blood cell. So in the direct COMS test, the DAT, no, the DAT or direct anti-human globulin test, the patient red cells are mixed with antiglobulin reagents containing the antibodies specific to the human immunoglobulin G or the complement proteins. So if the patient red cells are coated with complement or IgG, the antiglobulin reagents will bind to these antibodies, resulting in agglutinations or clumping of the red cell. So how would you interpret the results in your direct anti-human globulin? So a positive dot or a positive direct indicates the presence of antibodies or a complement proteins on the patient's red cells, suggesting an immune-mediated process. So this can help diagnose conditions like autoimmune hemolytic anemia or hemolytic disease of the newborn. For the indirect COMS test, the purpose of this test is used to detect the presence of antibody in the patient's serum or plasma that may potentially cause the immune-mediated destruction of the red blood cell. So it is commonly used in blood typing, the compatibility testing for blood transfusion, and screening for antibodies in pregnant women. So that is your indirect. So in the indirect or IAT, no, the patient's serum or plasma is first mixed with the red cell of known antigens, of known antigen types A, B, or RH in the test tube, in a test tubes. After an incubation, you have to add now your anti-human globulin reagent containing the antibody specific to the human IgG. No? So if the antibodies are present in the patient's serum, it reacts with the red cells. And the anti-globulin reagent here will bind to the antibodies, causing now an agglutination. So you have to look for agglutinations or clumping of the red blood cell. So if there's a clumping, it indicates the presence of antibodies in the patient's serum that can potentially cause an immune-mediated destruction of the red blood cells. And further testing may be needed to determine the specific antigen involved in its clinical significance. So that is your direct and indirect. So here I already discussed this, the anti-human globulin. So last is the cross-matching. Okay. So cross-matching class, no, is actually critical procedure performed prior to blood transfusion to ensure the compatibility between the donor's blood and the patient's blood. It is a serologic test that involves mixing a sample of the recipient's or the patient's serum or plasma with the donor's red cell to detect any antibodies that may react with the donor's RBC and cause an adverse immune reaction. Okay, so this is done prior to transfusing blood to your patient. So the cross-match is typically performed after the forward and the reverse typing of both the donor and the recipient. And it is served as a final check to verify the compatibility and prevent the potential transfusion reaction. Now, what is a transfusion reaction? It's the body's immune system attack that transfused blood, causing hemolysis of the recipient red cells. So again, in the blood banking class, no, the type O is considered as universal donor. This means that in an emergency situation, when the blood of the patient's type is not yet available or a known patient's blood type, the type O may be transfused to the patients. But take note, it should be a pack O red cell. Kasi wala na yon plasma, wala na siyang antibody, so hindi na siya magre-react. Kaya, pack red cell ang itatransfuse mo kasi na-remove mo na ang plasma and then na-remove mo na rin ang antibody. So what is left is red cell na lang. And the blood banking, on the other hand, AB is considered as a universal acceptor. Meaning the patients with a blood type AB can receive blood from other blood types, but can only be transfused to the patients who are blood type AB. Okay, so there are two types of cross-matching. You have a major and minor. The major cross-matching is a direct cross-matching of your donor's red cell, which are tested with the patient's serum, and then to demonstrate the antibodies present in the recipient's serum. On the other hand, in a minor cross-match, this is an opposite of your major. In a minor, you need a donor's red cell. It's being tested against the recipient red cell. Sa major kanina class, donor's red cell, no? With the patient's serum. Ito naman sa minor, donor serum against the patient's red cell. So this minor cross-match demonstrate the presence of any preformed antibodies in the donor serum that may cause hemolysis of the recipient red blood cell. So, pag mga plasma class, like for example, platelet lang, platelet ang i-transfuse mo, mga plasma lang, expanders, Hindi mo na kailangan ng cross-matching. Only blood type specific lang yan. Kung anong blood type ng pasyente, yon lang din yung blood type ng itatransfuse mo na plasma or platelet. Like for example, kung ang blood type ng pasyente mo ay type A, you don't need to have cross-matching na. Type A lang din na plasma ang itatransfuse mo or type A na platelets. And same with the type B, type O, or AB. Understood, class? Blood type specific lang. Understood? Hello? Estudyante pa ba ako or kumain na lahat? Hello, class?
Yes po,
Understood po, Doc.
Okay, last na lang. In cross-matching class, no, the blood samples are collected from the donors from both donors and recipient. So the donor sample consists of the donor's RBCs, while the recipient sample contains the recipient's serum or plasma. So again, in the testing of the cross-matching, the testing reagent used in the cross-match includes the patient's serum or plasma in the donor's red cell. So this patient's serum or plasma is mixed with the donor's red cell in a test tube or a testing platform. And you have to mix. These mixtures allow the recipient's antibodies to react with the donor's red cell. So the cross-match is observed for the presence or absence of agglutinations or hemolysis. Pag may agglutinations or hemolysis, may indicate incompatibility. Hindi sila compatible. So wag mo ito transfuse yun. Okay? So the cross-match is interpreted based on the presence or the absence of agglutinations or hemolysis. A negative cross-match or negative in agglutination, walang agglutination, negative ang cross-matching, indicates compatibility, meaning no detectable antibody in the patient's serum or plasma which are reacting with the donor red cell. On the other hand, if you have a positive cross-match, may agglutination, it indicates incompatibility, meaning hindi sila compatible. So suggesting the presence of recipient antibodies that reacts with the donor's RBC, making the blood transfusion risky. So yun class sa cross-matching. Okay? So thank you for your attention. So do you have any question or any inquiries regarding the lecture? Class, do you have any question?
None so far po, Doc.
Okay, so if you have no questions, so thank you so much. And then I'm going to send my PowerPoint lecture to your class coordinator. So may I see, sino nga ba ulit ang coordinator class? Nakalimutan ko na. Si ano ba? Sino nga ba yung na-send ko palagi?
Sa president po, Doc, si Alfred po ang kahas.
Si Alfred? Sino nga? Ano bang email niya? Ano ba email niya, class? Sa JMC? Hello?
Parang Alfred and kahas lang din po, Doc.
Alfred ang kahas ba? Okay, sige. Sige nga, itry ko nga. Tingnan ko lang muna. Wait lang, class, baka Alfred. Tingnan ko dito. Alfred. Alfred ang kahas. Okay, sige. Okay, so I'm going to send you my lecture later because I have my class, face-to-face class kasi class sa Fatima. Okay, so I need to go now to Fatima for another lecture sa micro. Okay, so thank you so much, class. Yeah, okay.
Okay
Thank
po,
you.
Doc. Thank you po.
Okay, thank you, class. Bye-bye. Thank you. God bless. Okay, bye-bye. Ingat kayo
Thank you po,
lahat.
Doc.
Okay, bye-bye. Oo.